evening, ladies and gentlemen. I am Fran van Heuverswyn. I'm the project manager of Flanders Vaccine, and on behalf of the board of directors of our organization, I would like to welcome you all at this 5th edition of Immunity for Health. Given the extraordinary time and the difficult time also we are facing for the moment, I would like to start by wishing you, your teams, and also your family a good health. So the COVID-19 pandemic has an unprecedented global impact and caused already many disruptions to our normal way of life. So also the way we are meeting and the way we are interacting with each other. So that's why Flanders Vaccine have chosen to turn the 2020 edition to a hybrid event. So everyone had the choice to be physically present or to participate from home. So Immunity for Health is the annual flagship of Flanders Vaccine. Flanders Vaccine is a member-based non-profit organization. So one of our major goals is to build bridges, connecting all the different stakeholders active in the field of vaccines and immunotherapy, to stimulate new collaborations, public-private partnerships, and innovation in this sector. We also want to focus on raising awareness on the benefits, but also on the risks of vaccine and vaccinations. So Flanders Vaccine has been established in 2016 as a platform by the 5 Flemish universities, by Flanders Bio, the bigger health cluster for life science in Flanders, and by a biotech company, Biomaric, focusing on the prevention and monitoring of infectious diseases. I also would like to acknowledge our strategic partners for their support, which are MSD, Janssen Pharmaceutica, GSK, Sanofi Pasteur, Pfizer, and recently also Zuiderpershuis joined. Of course, I also want to thank all our members. Together, we have built a strong ecosystem and network within the field of vaccines and immunotherapy. So, inspired by the input that we received from our members and also from participants at our previous events, we decided to focus this edition of Immunity for Health on vaccine hesitancy. In January, a first preparatory meeting took already place with different Belgian stakeholders to hear about their thoughts and interests. In July, a workshop was organized to identify and also map the challenges which are related to vaccine hesitancy here in Belgium. And today, some of these challenges will be further elaborated. We all know that vaccines prevent diseases, and we know that vaccines save lives. Yet, many parents are still hesitating to vaccinate their children. There is also a lot of misinformation circulating on the internet and also on social media. Also, the fast development of a potential COVID-19 vaccine by scientists around the world is raising public concerns about the safety, if there are side effects of the vaccine. So people are becoming more critical and they become afraid, which also may contribute to vaccine hesitancy. So health education and communication of correct and scientific-based information are certainly the major keystones to improve the current situation of non-grounded fears for vaccines and vaccination. So I'm very pleased that we can welcome some renowned speakers who want to share with us their view on different aspects of vaccine confidence, vaccine complacency, and vaccine convenience. So I'm especially pleased and honored that we can close this event with some closing remarks of our Flemish Minister of Welfare, Public Health, Family and Poverty Reduction, Minister Beke. And so before I give the word to Corinne Vandermeulen, I will briefly inform the participants online that they are in a listening-only mode, that we encourage that they ask questions. They can do this by clicking on the QA button and type their questions. The moderators here will gather all these questions and address them to the speakers immediately after the presentation. Except for the session supply and safety, vaccine supply and safety, we'll have the Q&A after the two speakers, so at the end of the session. People here in the room, of course, if they have a question, they can just ask the question live via the microphone. And the webinar will also be recorded. So now I pass the word to Professor Corinne Vandermeulen. She's also a member of the Board of Directors of Flanders Vaccine. She's a professor youth healthcare, and she's head of the Vaccinology Center of the University of Leuven. I know Corinne as a very gentle and dedicated person. We don't see her on the screen as often as other experts, but behind the screen, she is doing a great deal of work. I will thank you, and I wish you all a very inspiring meeting.
So also from my side, welcome to Immunity for Health here in Antwerp, but also everybody behind the screen at home. And I'm waiting for my slides, but I know the technicians have been preparing it very carefully.
Yep.
Okay, there we go. So, why talk about vaccine hesitancy? Now, prior to Corona, a lot of attention was given actually to the resurgence of vaccine-preventable diseases, where measles was actually the prime example of this worldwide resurgence. And when parents are doubting vaccines, or when there is a general shortage of vaccines, not enough children get vaccinated. And if not enough children get vaccinated, then you actually undermine your herd immunity that was so difficult to build up. And this herd immunity is really essential to stop the spreading or the circulation of vaccine-preventable diseases. Now, this was prior to Corona, and we actually hoped that with Corona people would understand why vaccines are really necessary, but we were somewhat surprised to see that very rapidly after the coronavirus occurred and after the insights became that a vaccine was necessary actually to stop this pandemic, that on the internet we saw the anti-vaccine movement voicing anti-vaccine feelings a lot more than even prior to Corona. And also on mass gatherings, the anti-vaccine feeling is being ventilated at an unprecedented pace. And if we will have a safe and effective vaccine to prevent infection and COVID disease, we will need to give everything we got to convince people that these vaccines are safe, effective, and it's really necessary to be vaccinated. So the climate now is so much different than when we started vaccinating children against polio. Now, when talking about a specific topic, it's always good to start with a definition, although I think that most of people are already aware about what vaccine hesitancy is. It is, as WHO set out, it is a delay in acceptance or refusal of vaccines despite the availability of vaccine services. Vaccine hesitancy is complex and it's context specific. It can vary from time to place and also according to the vaccine available. And according to WHO, it is rightfully one of the 10 threats to global health. And it is still in 2020. But vaccine hesitancy is so much more than what people usually think it is. If you hear vaccine hesitancy, people think it is loss of confidence. But actually, the definition is that it's the combination of 3 C's, namely convenience, complacency, and confidence, that makes the whole of what we can call vaccine hesitancy. Now, convenience, it is about having easy access to vaccination. How much trouble do you need to do to get your child or yourself being vaccinated? And it depends actually on the resources of your country, on the health organization of your country. It also depends on the availability of a national vaccination program, but also on doing surveillance. checking whether your vaccine program is working, checking before and after your program, what is your disease incidence. And it is actually all of this together that is, when we're talking about vaccine convenience, that is what we target. The second C is vaccine complacency, and that is somewhat difficult to translate. It is about self-satisfaction, it is about being lazy when it comes down to vaccines. These parents are usually not against vaccination, but you know, why go through all the troubles if these diseases are not around anymore? Why have your child vaccinating and being exposed to side effects when you don't see the diseases anymore? This is actually what is complacency about. But with vaccination, the work is never done. You need to repeat it with every child being born. And the last C is vaccine confidence, and this is also the most complex one. And vaccine confidence is defined as the trust in the effectiveness and the safety of vaccines, but also the trust in the healthcare system that delivers them. And this is what people think when they think about vaccine hesitancy. Now, vaccine hesitancy is what we call a wicked problem or a complex problem to which there is no one solution. And we definitely need what we call a transdisciplinary approach to solve this problem. It means that we need different solutions. And a transdisciplinary approach is different from a multidisciplinary approach, where in this cartoon you can see an elephant and different specialists are all looking from their angle to the same problem. And they will try to come up with solutions from their angle. But transdisciplinary approach is really working together with different disciplines right from the bottom, looking at the same problem together and trying to come up with solutions. And collaboration from the start is really key, and that is why we are here today. And lastly, I want to talk about Ubuntu. I don't know if you're already familiar with this African word. It means I am because we are. You are because we are. And this is actually what this vaccine is all about. It is about reaching these high vaccination coverage rates to reach herd immunity so that we can protect the most vulnerable persons in our society, those who cannot be vaccinated or those who do not respond to vaccination, so that they can stay safe and unharmed. It is about solidarity and about taking care of each other. Ubuntu is also applicable to the corona crisis. You are because we are. I am because you are. It is about everybody applying 4 simple measures. Keep your distance, wear a mask, wash your hands, and limit your close contacts. That will help us actually to dam this epidemic until safe and effective vaccines become available. Ubuntu, I am because we are. And we at Flanders Vaccine are very happy to have you here tonight for an interesting program for which we invited a keynote speaker for every C: convenience, confidence, complacency. And it is now my pleasure to introduce the first C of convenience, and it is Professor Nico van Dalen. He's full professor at the Faculty of Economics and Business of the KU Leuven, and he leads the Access to Medicines Research Center. He is intensely involved in health system design with the current focus on immunization, HIV, and emerging tropical diseases in a sub-Saharan context. Central in his research portfolio is a human-centered, system-based, and design thinking approach. Welcome, Nico.
Thank you, Corinne, for this kind words and introduction. And indeed, I want to try to explain a little bit about convenience, but also put it in the broader picture of hesitancy and the health system design. So you see the last mile, and that's already a very important point of introduction, that the last mile is not where the vaccine ends into the fridge of a health center, for instance. That's not the finishing point. The photo here you can see is a picture taken from South Africa, Soweto, where the first clinical trials were held some time ago, and you see immediately that this is the last mile. And if this is not working, then let's say the goal of the whole immunization efforts is not realized. So the goal is get this person immunized, and you see immediately a needle, a syringe, a protective clothing, a mask, a person, a nurse, and so on. So that's very important that all of these elements are there to get the system successful. This is my team, and Corinne already introduced transdisciplinarity, and in fact we are a small team, but I can just illustrate that we really need that. The people who are here on the team have degrees in civil engineering, in business engineering, pharmacy, IT, art, architecture, things like that, economy, social science. I think if we collect all that, we can think about this very complex problem from different angles and hopefully get better and more successful solutions. The three pillars of our approach are indeed, as mentioned already, the human-centeredness, the system thinking, and the design thinking. These are three elements we believe through all the projects we have been doing are very important to get, let's say, to a feasible and acceptable solution. Let me start with the human-centeredness. You see the picture there, and I already touched about, let's say, the previous picture, but here you see a very human content at the last mile. You see the baby, the child, that has to be there, for sure. We sometimes forget, does that child easily get here? Who's deciding for the child? You see the mother there, but in many more cases you see also not only the mother, the family, the grandparents, the father is engaged, and so on. You see also the nurse, very important, but specifically here, and this comes from our experience in Africa, but I strongly believe that also in our countries this is very important, is the lady you see in blue, that's the community worker. I think that lady visits, let's say, her community, knows what is going on, is coaching mothers and caregivers, and indeed can also be deployed into surveillance, also already pointed out as a very important element. So you need all these people very motivated to get the things done. Then on the top part you see the system approach. I will also show that later more in detail. And that's in fact that what we typically call as a supply chain or a health system is usually part itself of a larger system. And there are a lot of subsystems who have to work together and, let's say, jointly, not opposing each other. And sometimes this happens, as I will show you with some examples. The third pillar is the design thinking. That's something we learned from people who design products or houses or whatever. And they are typically user-centered. They think about who will use this house, who will live there. And then it has a couple of steps. We also structured that a little bit through the years. And I will not go into the details, but you see the picture there. It's the back of a skirt of a nurse in Kenya, where the question is, in fact, let me show you how you can save your kid from HIV. So the goal is try to protect your kid from HIV. That's the goal. And for that goal, we will construct a system to do that. And then in 5 steps, we talk about stakeholders, performance indicators, modeling, and then, of course, choices and options also already meant. There's no single unique best solution for everything. We will have options. And finally, we have to decide on these options. And I will also talk about that a little bit later, because this is, of course, an element we face also in the media now. What is the relationship between experts and decision makers / politicians? Okay, this is, hopefully you can read it, both in the room here and at home. This is just a structure of our, let's say, streams of projects. And we do a couple of things about childhood immunization. This is the left one. The second one, as you can see, is about, well, I cannot see it, I'm sorry. It's very, can you see it at home? I don't know. Very difficult. Anyway, it's the combination, allow me to explain it, it's the combination of climate change and immunization. You can say, How is this related? Well, it's about, here in this case, yellow fever and rabies. Yellow fever is transported by a vector called Aedes aegyptis. This is a small, tiny, let's say, mosquito, and that mosquito survives in places where it didn't survive before. So we have to be ready when this thing develops in terms of vaccination and immunization. We connect that to rabies because a lot of things of the human health have also to do with zoonotics and the health of animals. And of course, rabies, we can vaccinate the dogs. For other animals, it's not that simple, of course. But at least we have to realize that sometimes it's even beyond our human system that we have to look for solutions and designing of the system. Then you see HIV is a specific pillar, of course, where we also have a discussion and some projects on, let's say, prevention, long-acting injectables to replace daily pills, but also a vaccine hopefully will be there in the future. And again, we have to be ready for this immunization system to be performing. Then we can, of course, not escape COVID-19, and we turned into COVID-19 through, in fact, let's say, the emerging infectious diseases. And so WHO has a list of diseases which are not yet fully, let's say, covered by vaccination. There was a top 5 defined and taken over by CEPI. And CEPI contacted us to, let's say, and that was about halfway 2019, so before COVID, they asked us, can you already think about the supply and the convenience for this new to be developed vaccines? We started doing that work, and eventually in March, of course, the question came, can you slow down a bit on these 5 pathogens, and can you turn your attention and most of your efforts to COVID-19, which we are doing today. And then the 5th one, I do not want to, or the 6th one, excuse me, not forget, is in fact a kind of a decision support. We really need decision makers to support them in making their decisions, because it's not something you can calculate and then you have a single number solution. So we really have to work on that from that side. And we also have kicked off a research stream on that. So if I may reconnect it to the things already said about the system thinking, you have the prevention versus the outbreak. I think all of you are specialists, even much more than me in the field, and there's a lot of things to say about prevention and outbreak response. Coming back to the COVID-19, we are mainly now in the outbreak response, but hopefully through time we will go into the preventive mode. And these two are not independent. They live together, and at a certain moment they have to keep each other in balance. Another system thinking idea is prevention versus treatment. And we now treat a lot of people for COVID-19 consequences, but of course, prevention will avoid that treatment. And that's one of the very first things we learned in HIV. Now we all try to cure it, try to treat it, but of course in the future we hope that we don't need that treatment anymore. It will of course be a long-standing exercise because it takes decades of course to switch from the one system to another and get them into balance. Then the final one, the human behavior. I want to highlight 2 elements of that. One is in the HIV setting, where we learned that because people are not loyal to their treatment, they start, not of course by their purpose, but they start to develop a drug resistance. And if the, let's say, the disease gets resistant to the drugs, then all the offers again have a little chance of getting to their final results. So there we already had that balance between, let's say, so the balance between treatment and prevention, with on top of that a lot of human behavior helping or not helping out. And that's the same thing we see today here in this symposium, that here also human behavior in COVID-19, we see a lot of hesitancy popping up, a lot of things which are not going that well, and I will hopefully show at the end that in fact we really need to do our best, because otherwise we will miss in fact our end line. This is, excuse me, these are some partners we work with, but it's a diverse selection of companies, universities, and international organizations. So the human-centeredness, I already spoke about that a little bit, and indeed, immunization goal, I don't have to explain that. So the treatment should be, let's say, avoided or at least diminished when prevention pops up. But if we come to the modeling of these systems, I can add a couple of things. So about the vaccine, will these people have access physically, economically, financially, mentally, right? Are they hesitant? The theme of today, and much more will come later this evening. But also about the vaccinator. That person can also be scared. That person may not be skilled for the new things to come. Maybe we need new trained people, very new in the field, and so on. And will the whole thing be safe? Will the person not get other things coming up, like just the safety of the instruments, but also, of course, the disease? For who will we organize this? So there's a big discussion now about the fair and equitable allocation of the volumes of vaccines coming up. In an emergency, you do not have a vaccine for everyone. How will we solve that problem? I will also shed a light on that a little bit later. So it's indeed a discussion about target groups, vulnerable populations. But again, you may all agree that elderly people should be vaccinated first. But what if you do not have enough? How do you solve that problem? And then, of course, by who? Who is deciding this? Which are the experts, the regulatory people, the politicians, the businessmen? So all of these are stakeholders in the system, and they have to collaborate to get a final solution workable. This is, of course, I cannot deal with all the details here today, but this is a typical, very aggregate view of the system. So it can be applied for COVID, it can be applied for childhood immunizations or new and emerging diseases, but typically you have R&D efforts, but you see, if you take decisions in the R&D world, it has already an immediate impact on the downstream last mile and a bunch of other things. Let me explain one. They're all now vaccine candidates for COVID-19, which we already know if it's a good one, and countries and the world chooses for those ones, it has to be stored on minus 70 degrees, for instance, yes. If this is already decided in the lab, way to speak, yes, then of course the whole system has to be prepared for that. And we know we are not prepared. We have to take action on many points in that. So if it's not only a thing about physical thing, like manufacturing, distribution, storage, it also has a thing about funding. Will it be more or less expensive than, let's say, an ambient or just a fridge to be kept vaccine, you see? So we have to connect all these elements and try to, let's say, assess the impact of all these elements. You can read them, I think, and there are many things we have to deal with. And you see behind all of these elements and system points, you see that different stakeholders with different interests are behind. And that's very important. We can align them. Okay, here also you see at right bottom corner, let's say the outbreak circle, which is the one we want to see smaller and smaller in the future. Then there's a lot to say about design thinking. I will not review all of that because if you need more information about that, I can share that with you. This is a more structured way how you work with stakeholders and their interest and modeling and so on to get to a system design. But what I want to stress here, because it's a very actual theme, is the difference between experts and decision makers, right? What we do in our projects, I'm not telling that this is perfect, but we have good experience with that, is the fact you see there the girl is choosing between a donut and an apple at breakfast, right? If you ask a mother who is concerned or a father about the health of the kid, everybody would probably go for the apple. It's more healthy than a donut. Okay, this is a kind of a general belief. But I'm not so sure in a sense that if that girl has to spend a whole day in school doing sports, in a sports day, maybe at that moment you better give a donut at breakfast, okay? So it all matters. What is the context? What is, let's say, the stakeholders' position, but also, of course, you suppose you have the condition that you can only take one of the two and not half a donut and half an apple. So if you invest in a supply system for a vaccine, it's extremely expensive, also in R&D and so on, so you usually only have one moment or one choice or one option, and everybody has to agree, even if that option is imperfect on a particular dimension, everybody realizes and everybody goes for the same chosen solution. I think that's very important. So going to the 5 apples, I'm sorry, my counting is a bit difficult. Yes, 5 apples, right? So you see there 4 green apples and 1 red apple. What is the task, my opinion, of researchers and experts? They decide what are good apples, good-looking apples. All of these 5 come out of the analysis. These are all good options, but they're not equal. You see clearly there's a red and 4 green ones. So it could be that the red one is a very nice one, but also a very expensive one. And the green ones are a little bit less expensive, but they miss a little bit or do a little better on another side, okay? And I think the position of these 5 apples should be offered to the decision maker from, let's say, the expert and scientist, and then somebody else takes within a set of good solutions one solution to go ahead. That's my personal opinion, and as far as we worked it out in the past, it worked. So then coming to the, let's say, convenience part, I see my picture's a bit overruling my title, but this is something we worked out as a simplification, of course, for the neglected tropical diseases I mentioned. We studied here Lassa, Nipah, Rift Valley fever, and a couple of others. And you see clearly you have a basic production of the bulk, then it usually has to be transported on site, but is sometimes between continents to, let's say, a form filling and packing facility, and then that goes to a regional store. And then, of course, the distribution in country kicks off, right? That's not highlighted here on the picture. That whole network is a very complex one, a difficult one, because if you have to transport all over the world stuff on minus 70 degrees, for instance, this is not an easy thing to do. So this is a network for only some examples here. So it's a non-COVID. You cannot see that on the title, but this is a non-COVID network, but COVID is very similar. So then you see what does that gives you such a model. When you can see it more or less, it's a bit small, but on the top, this is for chikungunya, then you say, okay, if we have nothing now, and we start having a mass volume production right now, it takes a while before the first batches come out of the system. It takes long, this is a very difficult process, and so on. So you see, but at a certain moment, the first volumes come up, and if the vaccine is to be stored in a strategic stock, so not to be, let's say, deployed in an emergency situation, you can stockpile your vaccines until the outbreaks show up. Okay, that's the normal way of doing. And you see there the stock builds up in green, and then somebody has decided what should be a strategic stock to cover, let's say, the outbreaks you expect. And then the up and down, you see the small outbreaks, and then you cover each time you consume some of your strategic stock, you refill it, of course, because you want to be prepared for the next one. You see there are different regimes, different outbreak patterns. Some of them are seasonal, others have to do with other factors. So you clearly see that there are different outbreak patterns with different stockpile, let's say, modes. But at least it gives you, and that's very important, timely information for what is possible, okay? Then here, this is then turning to the COVID situation. By the way, I have to be clear, this is not, let's say, real-time COVID information. I do want to induce very difficult discussions, but the characteristics are there. So the difference with the previous slide is the fact that immediately as a batch is produced, it will be used for COVID-19 because, you know, we are ready, we are really eager to move ahead. So you see that we have a target of producing, yes, and then each time we have a cumulative consumption, and each time a batch is there, it is consumed. So that's why you do not reach your strategic target. We hope, of course, after 2-3 years, that we come into a situation of the previous slide. And by the way, if you would have very strong eyes, which I don't have, you see that if somebody very smart in the world tells you that you should start production and you will have a vaccine before the 1st of October, I think you heard that before, you see here mass production for this should have been started late July, which is not the case. Okay, but again, this is not real-time COVID information, but you know what I mean. Then if we embed that now in our COVID situation, I talked already about the vaccine supply is very complex. It's a bioprocess, it's not a chemical process, so it means in fact at the end of the process you cannot immediately see that the product is good. The only way to guarantee a good vaccine is the fact that you did your work very, very well. Nothing went wrong on, let's say, the road to the vaccine, and the smallest thing which is going wrong there, you kick the vaccine out because you have doubts. So the whole quality assurance, quality control, regulatory things are very, very strict and explains quite a bit of the long lead times for vaccines. We try to squeeze that. You know, there's some uncomfortable feeling about the fact that we produce the vaccine for COVID maybe faster, but there is some opportunity there. Before COVID, we studied the rotavirus vaccine, because also there was a higher need than the, let's say, the supply, and there was a question, can we do it faster? There are some opportunities to do it faster, so I think most suppliers try to build on those opportunities there. But I think on quality, there will be no compromise. And then, of course, for COVID, we start from scratch. There was even not very much known. It was known, but not very much. So what we typically call here in building such a system is the unavailability of all repository knowledge. We have to, by week and by month, build up that knowledge. So it means that our models continuously adapt and change. Data change, the structure of the model change, decisions are made on different levels. So we have to be very dynamic and adaptive, which is another characteristic of a transdisciplinary approach. Okay. Then validation is not easy, it's time dependent. I already explained that to you. The living model, I also talked about that, right? The ecosystem is also part of the game. Then maybe a final word on the allocation. So you have seen this volume. The network can produce volumes. These volumes are to be served to a demand, but that's of course, the volumes will be split and the demands will be converged in particular country demands, for instance. And this is, as you can see it there in, let's say, descriptive words, it is the health outcomes we want to maximize subject to diverse constraints. And to be sure, this is not easy to define in a sense. Okay. Where does it come from? There are some principles, of course. This is something you probably have already seen yourself. These are the guidelines of WHO, which they published. So how will we start with distribution? And if you allow me, so there's the goal of the system, which is already multi-objective, if you can read it nicely. There's some time aspect in there. There is some, let's say, priority aspect in there. There is also a buffer, which already hints to the strategic stock for stockpiling, right? So for emergencies, even in the COVID, let's say, rollout situation. And we have already some numbers where we can say, okay, let's try to figure that out. Then this will be built into a model. I will not go into the details, but the allocation model will be one of the very important models for the next months, as you can imagine, especially of these time-dependent shortages with time-dependent needs. Okay, and then there's another difficult thing. Because we have a network, that network gives some throughput, so that network we have established now can produce so many vaccines of these technologies and these characteristics. The countries will try to absorb that. There will, of course, be shortages in the beginning, right? So we will learn from that we would need more from the network, so we will play in the network, and so we have a kind of a circle, and this is, of course, something very difficult. Because where do you start? Do you start in the needs, or do you start in the supply? Because it's something which is really not independent. That's a very important characteristic of a system approach, and we can model that, fortunately. So, you see here also a way of, let's say, on a very aggregate way to model this. I like this one very much because here you see clearly what is the prevention, the planned immunization, and what is the emergency immunization with, of course, maybe campaigns. There are very different forms where you can do that. And, of course, these are not independent. The better you do in prevention, the less outbreaks, of course, and if there's an outbreak, also your planned immunization system hopefully can cope with additional efforts to this outbreak response. And then this is one to close. So already explained in the very beginning, and my circle is almost round. We have the nurse, we have the syringe or the vaccine, we have the patient or the person. It's not usually a patient, it's usually hopefully a healthy person. And I want to share, oh, this is a bit problematic because the slide has shifts. Okay, let me just visualize it. Okay. It's doable. So you see there the base case. Suppose we have a 95 availability of the vaccine, 5% stockouts. In several countries, this is not an exception. The workforce is available for 95%. Okay, and then you have a 95% population. This is the hesitancy. So the people are afraid of the vaccine. So 95% of the people show up to be vaccinated. If these are independent element, which is not, but suppose they're independent for ease of calculation, you see there we have an 86% of success, that all these things are there, and that, let's say, 86% of the goal of the system is realized. Suppose now the first one, the vaccine drops to 80% due to production problems, transportation problems, whatever, doesn't matter much what, so you see immediately what will be the consequence. Your final result drops to 72%. If you, for instance, take everything back on the good track, but you say the workforce is sick, is infected by itself, and goes to a 75% availability, you drop to 68%, right? Even if you, again, have a healthy, let's say, vaccination staff, but the people are very scared, and you go to 70% of, let's say, people who are getting to the vaccination, and to state it easy, 30% of, let's say, hesitant people, you go to 63%. And I definitely don't dare to put all three things. If they all happen at the same time, you can calculate yourself. So we will end up with, let's say here, 50% of immunization, which is definitely not enough, as Corinne explained, to get the things done, despite all the efforts we do now. So I think this should be an eye-opener for those who definitely don't see what an effort on all these different aspects means at the end of the day. Okay, so this is then my final slide. This is the COVAX facility, also known to you, I think. And if you look at that carefully, if you analyze that, it also contains the elements of this system thinking. It's the small circles you see with the arrows, excuse me. These are in fact signals that this is an iterative feedback type of element in the system. So we will definitely not be done after choosing our first options. We have to rethink, revisit, adapt until I think more or less the things get balanced. Voilà, this was my talk. I hope I stayed within the time limits.
Thank you, Nico, for this interesting talk. We do not often talk about vaccine supply in the medical world, so it is always insightful to have your presentations. I currently have no questions from in the Q&A part of the Zoom. Maybe I have a question. So in your systems design, it's we know vaccine hesitancy and convenience as well is country specific, is vaccine specific. If you design all these maps, how can you difference between the European context and a context of low and middle income countries, for instance?
Yes, so the aggregate views of the models are generic, so and then of course you translate that to specific settings, and of course settings different, so not all elements can be copied from one region or part in the world to another. Some of them can. For instance, what was striking to me is the recent re-emphasis of the WHO on communities. And that's something in our countries, if I may say, we have lost a bit. So that there's not that pressure on that. But in Africa and the low and middle income countries, specifically we work in, it is definitely still a very, very strong element. And some of these countries have even extended the investment of that because these people are very close to the population, or trusted, or respected. And they really have a kind of leverage effect on this type of things, especially in a crisis. Of course, for all regular business, they also, outside health, do a lot of good work. But I think for health, this is very important. Surveillance, convincing, help people to get to the healthcare facilities and to the information and to, let's say, the correct information and so on. So I think communities, to me, is a very generic thing we can reintroduce or re-emphasize. And it's still here in our countries, but I think we have to revisit it a bit and let's say, reconsider it as a powerful way to get things done in this matter.
So the data that feed your model will be still country specific?
Once you go to the country models, they are of course country specific. I didn't touch it, but we're currently working on the COVID-19 model for Norway. But the nice thing about Norway is that they say, look, we are also a very dispersed country with small communities which in winter are very hard to reach. Well, in low and middle income countries and let's say the tropical areas, you have the same thing. It's not snow, but it's a different kind of thing. So we can learn a lot from each other in transportability of the models. But of course, the data definitely have to be instantiated for the specific setting.
Okay, thank you. Any other questions in the meantime? No, if not, it is my pleasure to ask Dr. Lieke van der A, because within the session of convenience we have a small subsession on vaccine supply and safety. And Dr. Lieke van der A, she is a scientist at Cienzano. She works at the Service Quality of Vaccines and Blood Products, which is an official medicines control laboratory. And this has a legal activity for quality control for vaccines intended for human use and also for blood, products derived from the blood. Thank you.
Thank you. So yes, I will explain to you what we do as an OMCL and how we monitor the quality of vaccines after licensing. So during the development of a vaccine, the manufacturer needs to collect data for the marketing authorization dossier. And basically there are 3 sets of data. So first there's the data from the preclinical studies in which the manufacturer needs to demonstrate the safety and the mode of action of the vaccine. Secondly, we have the clinical trials in which the safety and the efficacy of a vaccine is demonstrated. And a third set of data is the data that addresses the production of the vaccine. So this module in the dossier is called CMC, standing for Chemistry, Manufacturing and Control. And with the CMC data, the manufacturer needs to demonstrate that the manufacturing process is robust, reproducible, validated and controlled to ensure the ongoing supply of the vaccine after licensing. So vaccines are biological products and they are produced in mammalian cells. They can be produced in yeast, bacteria, eggs and plants. And they are therefore also subject to batch variation. The marketing authorization applicants needs to demonstrate that the batch consistency is within acceptable limits. For this, they need to validate analytical methods to assess the quality of each individual batch, and they need to determine release specifications. So to assure safe and good quality vaccines in the EU, we have the following regulatory network in place. So first we have the European Commission, so DG Santé. They're responsible for the EU legislation around medicinal products, and they are also responsible for granting the marketing authorization. So secondly, we have the European Medicine Agency. One of their tasks is the assessment of the marketing authorization dossier. And the third organ is the EDQM, the European Directorate for Quality of Medicines. One of their tasks is that they are coordinating OMCLs, so labs that do testing on medicinal products. They also are responsible for the European Pharmacopoeia, and they are responsible for the Biological Standardization Program. Under this program, reference material is developed that can be used in the assays. Also, we have the national competent authorities. So in Belgium, this is the Federal Agency for Medicines and Health Products. One of their tasks is the GMP inspections. So hereby, the inspectors will visit the production sites for vaccines, and they will verify that the manufacturer is producing the vaccines according to good manufacturing practices, but also that they are producing the vaccine as was stated and approved in the marketing authorization dossier. Another responsibility of the national competent authorities is the batch release. So we at Cienzano have this responsibility. And for this, there's a legal basis. So since 2006, we are officially recognized as the OMCL for vaccines. Thus, the main goal of the EU legislation and the supportive structure of the competent authorities and OMCLs is to ensure good, high standard and consistent quality vaccines for human use through the EU. And the current legislation is in place that was adopted already in 2001. So the individual competent authorities and OMCLs are responsible for the release of individual batches according to defined rules. So these rules are the Official Control Authority for Batch Release Procedures, or OKBR. And we have a network of OMCLs in the EU, located in the different EU member states. Under these OKBR rules, it is stated that every vaccine batch intended for the EU market is tested independently from the manufacturer by the OMCLs. The EDQM has developed specific guidelines for each type of vaccine product. And in these OKBR guidelines, it is described first which testing needs to be performed by the OMCLs. So we as an OMCL, we will only test a few critical parameters with focus on potency and safety. Secondly, the guidelines, they describe the information that the marketing authorization holder needs to submit to the OMCLs. So for every batch, they need to provide us with a summary of the production the quality control results, and also a summary information on the finished product. So this is, for example, information on the production and the expiry date and the number of doses of that batch. We also have the European Pharmacopoeia. This is a single reference work for the quality control of medicines, and the individual monographs provide a legal and scientific basis for all the different assays that are performed. In the marketing authorization, it describes the release specification that were proposed by the applicant and that were approved by the regulators. So for every batch, they need to be compliant to the specifications in order to be released. Here I show you an overview of this OKBR procedure. So after the production of a batch, the manufacturer will take samples and they will send these samples to the OMCL. We can then start in parallel with the manufacturing the testing of this batch. And when the manufacturer has finalized their testing, they can submit an official request for batch release. So again, they will provide us with a production protocols, they will send us their quality control results, and they will provide us with the summary information on the final lot. So we will review all this documentation, and we will verify whether the quality control results from the manufacturer are compliant to the release specification. Our results also need to be compliant to these specifications. So if a batch is compliant, we will issue a release certificate. We will provide this to the manufacturer, and at this point, the manufacturer can then release the batch to the market. However, if a vaccine is not compliant, we will issue a non-compliant certificate to the marketing authorization holder and to the network of OMCLs. And in this case, the batch release is forbidden. So we have a network of OMCLs, so we can share the work, and we have a mutual recognition in place. So if a batch is released by one OMCL, it can be marketed in all the other EU member states. All the OMCLs work under the ISO 70025 accreditation, so it means that we work in a quality management system, and all the assays that are performed by us have been validated, the staff is trained, and all our activities are documented and the results are archived. We are audited by the national accreditation body, and in addition to this, the EDQM is also organizing mutual joint audits. So hereby scientists from one OMCL are trained to be as inspector, and then they will visit other OMCLs to verify that they are working in compliance to the ISO 70025 rules. So with this, we can create trust on the performance of OMCLs among the network, but also to the manufacturer, the regulators, and of course the public. So now for COVID-19, we are seeing an accelerated development for vaccines. So I would like to clarify hereby a few things. So first, with regards to the marketing authorization. So for the new COVID-19 vaccine candidates, they should meet the same requirements as any other vaccine. Secondly, the accelerated development is partly based on prior knowledge and new platform technologies being used. And EMA and the national regulatory authorities, they have put in place accelerated assessment strategies and are interacting on a regular basis with the manufacturers to support them in the submission of the marketing authorization dossier. For the quality control, also for COVID-19 vaccines, every batch will be subject to the OKBR. And we are currently interacting with the manufacturers. So we are currently defining the OKBR strategy and developing specific guidelines for the COVID-19 vaccines. We are also providing guidance to the manufacturers to navigate the OKBR procedures. And we are currently in the process to transfer the methods from the manufacturer to the OMCLs. So to conclude, we have a strict regulatory framework in place to ensure the good, high standard and consistent quality of vaccines for human use throughout the EU. During the development, the manufacturer needs to determine release specifications for their vaccine product. Every vaccine batch intended for the EU market needs to be released according to the OKBR procedures. And every batch intended for the EU market undergoes rigorous testing, not only by the manufacturer, but also by the OMCLs. So hereby, I would like to finish, and I'm happy to answer questions later.
Thank you very much. It's always insightful to hear how much effort is being put in assuring that the vaccines that come to the market are indeed have the required quality. So, but questions for Dr. Lieke van der A will be asked later, can be asked later. The people at home, they can already send their questions through the Q&A part of Zoom. And then I would like to invite Tine de Koene to the stage. She is a very young and enthusiastic researcher. She's the founder of Vaxsure. And Vaxsure is a company that has developed a patented product that ensures patients, young and old, that an administered vaccine has not lost its efficacy during transport. And with this product, they focus primarily on developing countries where the need is the greatest. But the product can also have an added value for all countries where vaccines are stored, transported, and administered. Thank you, Tina.
Thank you. Thank you for the introduction. I'm really happy that I can present Vaxsure to you all guys today. A little bit more about myself. I'm by education a product designer who has an enormous passion for the African culture. And combining both, I focus my studies and as my thesis on transportation of vaccines in developing countries, resulting in the patented product Vaxsure being created. The story started in 2015 when I went to Tanzania to do field research. I wanted to learn a lot more about the transportation of the vaccine, so I visited a lot of big hospitals, but also the small hospitals in the little cities. In 2016, I completed my thesis with Professor Dr. Pierre van Damme by my side, and I received 2 awards for my product. In 2016, I also started working and traveling, and on my last travel, I discovered that I really actually never stopped thinking about Vaxsure, and I really wanted to go further with it. So in January 2019, with a big yes of the team, with a fresh energy, Vaxsure started again. Let me tell you a little bit more about the situation. Like everybody knows, everybody comes in contact with vaccines and everybody needs vaccines. The product is focused on the difficulties on the cold chain. So when a vaccine needs to be transported between the temperature of 8 degrees Celsius, when it comes outside of that cold chain, we don't have the certainty that the vaccine hasn't lost its quality. The whole journey of the vaccine is a long journey with a lot of obstacles, and it's not easy or obvious to keep the medicine within the cold chain. If we divide this process in 2 phases, we have the first one, which we're developing the product and transporting it in big quantities to developing countries. There is the cold chain more or less manageable. When we go to the second phase, where the vaccine is transported within the developing countries, there is the cold chain harder and difficult to control. That's also something I saw in the field. Refrigerator that doesn't work, vaccines laying around, and unreliable materials. The market, a rough estimation of the total market size is 2.5 billion vaccines per year, where Belgium is one of the biggest pharmaceutical players. An estimation of the market size of freeze-sensitive vaccines is 1.6 billion vaccines each year, where the research that conducted by PAD in 2007 has shown an exposure to freezing temperatures throughout all the segments of the cold chain is 16.7% in developed countries and 35.5% in developing countries. If we combine that with numbers from the WHO, we estimated a loss or an exposure of 90 million vaccines in developed countries, but 318 million vaccines in developing countries, and that's something I want to challenge. So the product, the solution is Vaxsure. That's a vaccine cap that blocks itself when it comes in contact with temperatures outside of the cold chain, so it's easy to detect the damaged vaccine. The principles are that when the Vaxsure is affected on the vaccine vial around the stopper and cannot be removed. When a vaccine freezes, Vaxsure creates an irreversible physical barrier preventing the penetration into the stopper. When the caregiver wants to vaccinate, the syringe needle will block on Vaxsure, so the caregiver can only take a new vial and try again. So it's a tiny product with a big impact. The competitions today are Vaccine Vial Monitor, the freeze marker, and TempTel, where the first two are indicators, so they change of color when the vaccine is exposed to the wrong temperatures. And TempTel tells a story of the cold chain. The benefits of Vaxsure are that Vaxsure is an integrated product of the vaccine vial. There is no need for a temperature reading. The use of frozen vaccine is prevented, and the patient's warranty of effective vaccinations. So there's no negative impact on the vaccination statistics. There are a lot of values for a lot of different people. The first of all, the vaccinee, they have the certainty that the injected vaccines work and it hasn't lost its quality. The second one is the World Health Organizations and others. There ensures a successful vaccination. Today, a lot of investments are already being made by the indicators of the vaccine vial, but Vaxsure's indicating is many more times more reliable than the current indicators, and it makes it impossible to administer uncompromised vaccine. The vaccine producer as well, within the implementation of this new product, the current malfunctions in the cold chain will become visible. So a corrupt vaccine will be lost, and they will result in an increased production of the vaccines, and ultimately the produced vaccine will maintain their quality. Today, Vaxsure is still a prototype, but we will aim for less impact on the current gap, so we will aim for a product that the lowest impact of today. The Sustainable Development Goals, we also fit pretty good in that, and most of all in Goal 3. Goal 3 is the good and the well-being health, and there is the second and the 8th goal. Within this goal is where we fit perfectly, and it's the end of preventable deaths of newborn children under 5 years old, and an access to safe, effective, quality, and affordable essential medicines and vaccines for us all. The team of Vaxsure is myself and Professor Dr. Pierre from Damme as a guidance in the vaccine world, but also we can count on financial advice of Erik Bosman, and we are selected by UI for the strategic process of the whole business, and that's Arthur and Jelle, and also Wouter de Smet as an innovation leader. I know it's an ambition to change the current production way of vaccines, but we strongly believe that Vaxsure can have a big impact on the health situation in developing countries. So thank you for listening.
Okay, thank you very much, Tina. Yeah.
Well, thank you, Lieke and Tina. I will start with a question I had myself for Lieke, and then we also will take a question from the audience. When I saw your talk, and I agree with Corinne, this sounds very reassuring. There is a lot of steps to assure and assess the quality of vaccines. And I was just wondering, as we know that a lot of people who are hesitant believe that sometimes vaccines are developed too soon, too quickly, too early. Is all that information also accessible, I would say, in real layman terms? So in a kind of fact checker or frequently asked question document from Cienzano or from the EMA to well explain, but I would say in very simple words, how well we can reassure people about the check of the quality of a vaccine. Is that available, or is that something that people are working on for the near future?
At the website of Cienzano, we do have a description of our activities, but maybe we could improve this communication more, so that actually we were happy that we were invited to this symposium, because I think the work that we do, I think it's not really well known, even for people in the vaccine field. They are not always aware of this really rigorous testing by OMCLs, and that OMCLs exist. So I really agree that we should do more, and maybe we should put more information on our website. But so it is available, but maybe we should be more clear on this. The EDQM also provides this information, but it's indeed maybe more specific for those in the field, so for the manufacturers and the OMCLs and the competent authorities. So I think that's a take-home message for us maybe, that we should try to improve the communication. Yes.
Yes. Are there any questions from the audience here? Okay.
Hello, I have a question for Lieke van der Aa. You mentioned the mutual recognition from the European member states for the OMCL work. Now that we are facing this global pandemic worldwide, is there also, are there discussions ongoing between different regions? I mean, outside Europe, do we see America, Europe, Asia, maybe Africa, also discussing maybe how we can accelerate the quality checks that you do in order to make sure quick access to, when you, for example, release vaccines, are they only for the European market, or could they also serve for other regions than Europe only?
Good, so if I understand the question correctly, you ask if we also do quality control for the outside EU markets. Okay, so yeah, so first difference, so we are lucky that we are in Europe because we have harmonized procedures, so actually we can accelerate the access to vaccines because the OMCLs and the authorities are working together, so I think that's an advantage. Then the different countries, usually they have all their own regulation in place. So in the US, they have their own procedures. In Japan, they have their own procedures. So that's actually very complicated for manufacturers because they need to be compliant to all these different types of national legislation. What I haven't mentioned here is that we are also working with the WHO. So the WHO is also responsible for the distribution of vaccines in the low and middle income countries. And the WHO, they have their own specific guidelines in place. So first, they have a different review process. So they work with what is called a pre-qualified vaccines. So as with EMA, if a manufacturer is interested to distribute their vaccine in the low and middle income countries by the WHO, they also have to submit a dossier, so this is a pre-qualification process. So there's also an assessment performed on this dossier. And if the WHO approves this vaccine, it will end up in a sort of short list. So if the WHO wants to start a vaccination campaign in a specific region, the vaccine manufacturers that have this pre-qualification status, they can then respond to any tender from the WHO, and then they can be asked to do this, to provide the vaccines. So we have a technical service agreement with the WHO, and for any vaccine distributed by the WHO, they also need to undergo a batch release process. But for the WHO, it is not required that testing is performed independently from the manufacturer. So in this case, we would only receive the protocols and the quality control results from the manufacturer, but we would not necessarily do testing. However, the WHO does like to have this data as well. So as we have this technical service agreement in place, they may, for example, ask us that for certain vaccines that we test 20% of the batches produced. So not all batches that are distributed by the WHO are tested, but if we test 20%, they still have a good indication on the consistency of the production. And also during the pre-qualification assessment step, so if there's a new manufacturer, the WHO may also contact us so they can send us samples, and we will verify the quality of this vaccine product. So if we show that this product is conforming the release specification that the manufacturer provided, the WHO also takes this into account in the assessment. I hope this clarifies your question.
I have a question for Tinne, and in fact it's just where are you now and what is the next step? I think that's something I would like to know.
Yeah.
And the second one is a very practical one. Do you see this kind of device on all vaccines, or do you say we take just one vaccine per package?
Okay, I'm going to answer the second one first. I think it needs to be on every vaccine bottle, because when you go to the last mile and the last step is going from a little hospital to a small city, sometimes they only take one vaccine. So we need to prevent them as well of the damages in the last mile, so it needs to be on every vaccine bottle itself. And the first question was where I am now. So I am here. I'm really happy that I can present Vaxsure. But now we are talking to potential partners to collaborate. I know I cannot make this product on my own, so I need partners and I need people to collaborate with us. So that's what I'm doing right now. And then we need to fine-tune the product. So that's the second step. So partners, then the final product, and then getting data for the rest of the product.
Okay, thank you.
Are there any questions from the audience? Yeah.
Yes, I have a question for Lieke. Thanks for the very nice overview that you gave. Experts and people involved in the development of vaccines know that they will be safe, at least the vaccines that will reach the market. But what we see in the daily news is that there is a huge focus on this acceleration of the vaccine development, and that quite a lot of people think that this goes hand in hand with a lower or suboptimal quality. What you can develop in 10 months or in 12 months cannot have the same quality as what you develop in 10 years. At least that's what they think. My question is, will Cienzano or the authorities do a huge information campaign towards the lay public to restore the trust and to be sure that everyone thinks that it's of good quality, and perhaps also to some of the HCPs that will be involved in the vaccination process, because you also see that among some of the HCPs, at least, not all, far from, that there is also lack of trust in this accelerated development.
Yeah, so for the approval of vaccines, so this is a responsibility of EMA and the regulatory authority, so the Federal Agency of Medicines in Belgium. So to my understanding, we are now coming close to having a vaccine early next year. That's the estimation. And there will be a vaccination working group set up in Belgium, as we need to determine how to distribute the vaccine in Belgium, which is also a challenging task, I think. And this is a responsibility of the FHGG, so the Federal Agency for Medicines. So I think it's a job for them, working together with the different authorities in Belgium to communicate very clearly to all those involved, all the stakeholders, and of course the public, how we will do this distribution, and also to ensure. So I think this is something at the level also from. So I think we have a complex organization on politicians, political system, but I think there's a combination with all the different working groups that we have currently to communicate this to the public. And I think what's important also is that the Federal Agency for Medicines, they are also responsible for the pharmacovigilance, so the monitoring of the safety and efficacy for these vaccines. So for this, the agency is already working with Cienzano and with other experts to see how they can collect this data. So this is already in preparation. So Cienzano is supporting the Federal Agency for Medicines for collecting all this data. Well, already we're collecting data, but also for after the vaccination to monitor the safety of these vaccines. But yes, I know there's a specific working group that's for the vaccination and the implementation that will be set up. So this will follow shortly, I think.
Okay. Any other questions?
I think that's another question for Lieke. what do we have to understand under the exemption of the liability clause? And that refers to the APA of the future COVID vaccine of AstraZeneca. And indeed, that's also a question that has been circulating in the media. So,
to my understanding, so I may not know all the full regulatory details, but so to my understanding, so the European Union, they have put together a large budget, large amount of money to help manufacturers during the production or the accelerated production of vaccines. So for example, there are now manufacturers that are still in the process of the clinical trials, or maybe they will just start with the phase 1 study, but they have already started putting together the production sites for vaccines, and they have already started producing vaccine batches, so that once they have the marketing authorization agreement, they can immediately distribute the vaccine to the market. So for this, there's a liability clause in place. So in case a manufacturer has started the production and building these production sites, if they do not get through the 3 clinical stages of the clinical trials, and they cannot get a grant agreement, then in this case, the EU will take up the liability and they will take all the costs for this production. So that's, for me, I think this liability is only addressing the costs involved in the development, but if a marketing authorization is granted, then the manufacturer has a legal responsibility for their product and that it is safe and is of good quality. So that is not changing, to my understanding.
okay, thank you. And I think that's also very important to make, I think, that difference, because it circulates a lot. It doesn't help the people who are hesitant, because then they say, okay, who is responsible for the side effects, if any side effect would occur? And it sounds like exemption of liability is like the companies that are no longer responsible for their product. From your understanding, it has to do really with the responsibility of developing the product, which starts indeed already in parallel with conducting the trials. So that's a huge difference. And I think also that needs to be well communicated to the public at large, because we experience or receive a lot of questions to better understand this. So it's really something that should come in a kind of a frequently asked question document. That would help, I think, a lot of countries in Europe.
Okay. Thank you both very much for your interesting talks. And then we move on actually to the next session, which is the session on confidence.
Yes, I'm just looking at the technical staff to know whether our guest is online.
Yes, she is.
Oh, she is, fantastic. So, good evening, Heidi. I hope you can hear us.
Yes, loud and clear.
Fantastic. Hello. Greetings from Antwerp. I assume you are in London. So let me introduce you. So Professor Heidi Larsson is the director of the Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine, where she is a professor of anthropology, risk and decision science. And I can add to that that she's also associate professor to our university and works also partly in our Center for the Evaluation of Vaccination. So it's always very nice to introduce a colleague who is currently in the UK. She has a career, or she had a career at UNICEF. She was heading the Global Immunization Communication, and her research focuses on the analysis of social and political factors that can affect uptake of health interventions like vaccines, and that can influence policies. So I think Heidi is really the right person to be with us here tonight. And she very recently also authored the book Stuck, and I have the book here with me, so I can show it to the audience. I received it from Heidi because it's not yet available in Europe, but you can perhaps tell us when it will be available in Europe. It's now on the market in the US, and it's on how vaccine rumors start and why they don't go away. So, Heidi, it's my pleasure to have you with us from a distance, and I would say the floor is yours.
Thanks very much, Pierre. This is my first blended meeting where some of you have the opportunity to be together, and I'm the odd one out here. I'm going to shift to share my screen for the slides. If I get it right here on my very busy screen here. Okay. Can you see this?
We can, thank you. Yeah.
Okay. I'm gonna start by talking a little bit about the current vaccine confidence landscape, pre-COVID, as it were. We published a pretty big paper in the Lancet a couple weeks ago called Global Trends in Vaccine Confidence. And we've been looking at the issue of confidence. My group is quite multidisciplinary, the Vaccine Confidence Project. We've got modelers, anthropologists, psychologists, epidemiologists, social media analysts, and that's a growing group. Just really trying to get a handle on what are the things driving people's decisions around vaccines globally, and how is it changing over time and place. So in 2015, we realized that we had learned a lot about the nuances and conversations and emotions of a lot of this social media exchange and through qualitative research. But what we needed was something that was a bit more nationally representative, some kind of index where we could really look at change over time. So we introduced the Vaccine Confidence Index. And the paper in the Lancet looks at the data we've collected between 2015 and 2018, 2019. This index we're using in Europe, and actually the 2020 study was led from Antwerp, our European headquarters, as it were, for the Confidence Project. But we've been 2015, 2018, and 2020. So as you can see, this is actually a beautiful map figure made by the Financial Times. They took the raw data from our paper, and the index is on 4 domains: the safety, the effectiveness, the importance of vaccines, and compatibility with religious or other beliefs. So it's quite a spectrum across the world. We also have our own maps in the report, looking at 2015 on the left and 2018 on the right. Why does this matter? Well, I think if we understand the fertile ground that we have for receptibility or refusal of vaccine, that can help us as we anticipate the introduction of a COVID vaccine, inshallah, as they say. So the good news is that overall, particularly in the domains of confidence and in the importance and the effectiveness of vaccines, trends are looking a little better. As you can see, the dark red is the least confident, and the dark blue most strongly agree in the importance, effectiveness, and safety of vaccines. But that's not true everywhere. As you can see that, we see some lightening of the colors and more of a shift to blue. But if you look at North Africa, for instance, particularly around effectiveness, they're getting more skeptical. We see that South American countries that historically have been the poster child of vaccine confidence is waning in its confidence. Safety in particular is always the sticking point for communities in publics. Generally, the domain of confidence and importance is the strongest globally, and those numbers always drop when it comes to safety. So you'll have people say, yes, of course they're important. And when you say, do you think they're safe? I don't know. So that's the type of, but you can even see more clearly here how Africa particularly in the north, is actually getting less confident, a little more skeptical, and that's not great in some of these areas that need it more than anyone. But now I'm going to move into some of our work around the coronavirus vaccine, and I saw this quote in the Christian Science Monitor, which I love and I think is important to frame any survey you see about acceptance of a COVID vaccine. This is a story about the coronavirus vaccine, but not about the vaccine itself. It does not exist, nor whether it will be efficacious. We just don't know yet. So I think that any survey you see has to keep that in mind, which means also it will change when we know if there's a vaccine, if there are many vaccines, what are their effectiveness and safety, and what is the state of the epidemic at the time, because that will just help people decide whether or not they're willing to take that even small risk. We're doing a lot of global work, both in surveying, social media analysis, local qualitative research, often in-depth interviews, but we're having to do more and more of it online or in phones, but we are doing it at multiple levels. As you can see, it's highly varied. DRC actually had some of the least confidence in taking a possible COVID vaccine, but I think there's a lot of reasons behind that between conflict and uncertainty, and we're seeing similar things. Actually, the confidence around Ebola vaccines has actually gotten better, but that's a very tangible issue. One of the things we see in Africa is some COVID denialism, and that's partly because for some reason we're seeing, the suggestion is that because of the age demographics, we're seeing different fatality rates than we were seeing in Europe, but there's still a lot to be known. But in media headlines, you often see X% of the population would not take a COVID vaccine. Well, those headlines often bundle the I would not take, definitely would not take a vaccine, and I might not take a vaccine, which I personally don't think is particularly honest, because I think it's totally reasonable for people to be uncertain now. But the reality is we do have, and the bright orange are the percentage of populations that strongly disagree they would take it. And those, I think, are the most likely ones to not change their mind about that. The gray may not tend to disagree. You could still have a conversation there. But the real point is, for most COVID vaccines, is that in most conversations, you've got more expertise in the room on this, but I mean, I'm hearing 65 to 70% vaccination will be needed to achieve a kind of herd immunity, community immunity effect. What these disagreeers, what matters is not that they're not the majority of the population, but the tipping point phenomena, because we do not have a strong enough base in some countries to get herd immunity. If just even a small, a strong anti-sentiment that knocks that down a few points, it can push us under herd immunity. So we should be looking more at a tipping point phenomena rather than thinking, oh, is it the majority or the minority? We need to think of it in that, if you look at it in political terms, the swing group, because the swing group can make a big difference even when it's 1%. This is just, this is another perspective on it. These are more countries than we had. This is from the World Economic Forum. They ran another survey on willingness to take a COVID vaccine. But the dark red and orange-ish are the either strongly disagree or tend not to disagree. So we have a highly varied picture here in terms of confidence around a vaccine. To me, what's very, very interesting is Brazil, because in our global work on background vaccine confidence, actually, their confidence overall in vaccines have had some significant drops in the last 5 years. Even around the Zika outbreak, we were doing a lot of local qualitative research. There were quite a few rumors circulating that actually the microcephaly was really related to some bad MMR vaccines. And there's still a lot of misinformation, and that rumor for some reason has stuck. So what's interesting is there seemed to be more confidence, optimism, willingness to take a COVID vaccine, probably because it was hard hit by COVID, but also it's really there's a lot of the trials there. There's a lot of international collaboration, so hopefully maybe there's some more awareness about the vaccine than in some countries. There's a lot of dimensions that will, of trust that will affect the COVID vaccine acceptance. It's not just about its efficacy and safety and access to it. Do you trust your government that's requiring it, recommending it? And that, again, some countries, that relationship between trust and government will influence a decision more than others, as you can see here. The other domain of trust is trust in the medical professionals. That is much more a stronger lever of trust in a vaccine. That's probably no surprise to anyone in this meeting. But I think one of the big areas where we should focus in our preparedness for a COVID vaccine are for the frontline health workers and people who will be giving vaccines, because if they don't have confidence and they're not well prepared to face what are going to be a lot of questions from the public, it's going to be much more difficult. So I think it's an absolutely crucial group that we need upfront to really engage and prepare for any introduction of a COVID vaccine. One thing we asked a whole battery of different kinds of questions because we wanted to understand too, is our people's hesitation or acceptance of a COVID vaccine consistent with their compliance with other COVID control measures? So we asked about social distancing, hand washing, masking, self-isolation, a number of different things to look at how does their willingness to take a COVID vaccine align with those measures. Because if they were compliant with everything else, but didn't really think they'd take a COVID vaccine, that was about the vaccine. But some people are refusing other measures, and it just fits in an overall sentiment and probably relation with trust in government. But we also asked, would the country of manufacture affect your decision? And I was actually surprised. I thought it would influence, but I didn't realize it would be so high. 65% either strongly agreed or agreed that the country of manufacture would impact the decision. So these are the kinds of things that to prepare for in the realm of possible questions and issues that publics can raise. The other thing we've been interested in is in thinking about vaccination in general, how has the whole experience in the COVID pandemic and how the government has handled it and your whole experience and during this time, has it affected your thinking about vaccines in general? And actually only 12%, this is from our global study across all the countries. This this pie chart varies per country, but only 12% said that they would be less likely to take vaccines generally after this whole experience. This is partly because, against what we had hoped as a public community, that in the face of this highly fatal virus and disabling illness, that the people who were more anti or questioning of vaccines would maybe see the value of vaccines more. Instead, what's happened in this environment, we have seen in our social media analysis, and we look at billions of posts and trends across countries all over, and there has been an absolute amplification of anti-vaccine sentiments and groups. And what's happening is they're joining up with those who are protesting against distancing, protesting against masks, some of them getting very focused on some of the vaccine platforms. There's a lot of not just anxiety, but anger about a vaccine that might mess with their DNA. So that's another area we think about building confidence in the vaccine. We've got a lot of work to do in building confidence in the new platforms. This is not just about a brand new vaccine for the public. This is about brand new platforms that have never been used before in some cases, and that's raising as much anxiety as the product itself. In the US, there was a recent Pew study looking at May compared to September around willingness to take a COVID vaccine. And what I found striking about this particular study is that it's almost equal from no matter your gender, race, ethnicity, age, or education, the drop in willingness between May and September is really striking. And we see in our own surveys, for instance, in the UK, our end March survey on willingness to take a COVID vaccine, only 5% of the British population said would absolutely not take a vaccine. That number's gone up to 15% who would not take it just in last month's survey. And we see that across Europe also. So we're also witnessing what colleague wrote during the H1N1 pandemic. She had written per perspective as a GP, what she called the emotional epidemiology of publics, how at certain times, depending on how you feel threatened or not, your anxiety about illness or not, really affects it really changes over time. So I think when we get the vaccines, what the state of the pandemic and its perceived threat will really be an influencer. You know about the lockdowns and the demonstrations. I mean, this is the US, but we've seen them in Berlin, in London, and a number of places. We've seen 5G towers burned down here in the UK. A lot of people threatened, and I think this is happening in different settings. This is about something much bigger than a vaccine. These are our deep sentiments about liberties, about choices, some of the same sentiments that have been driving questions around vaccines. There's also a lot of breeding of distrust and suspicion. There's been a lot of fingers pointing to Silicon Valley and the tech industry, Facebook in particular, to stop the misinformation, turn it off, take it down. But it's just not that easy. I'm in a lot of discussions and working with Facebook about how do they triage what is a harmful misinformation and what is legitimate that you can, without taking away people's right to expression. And it's just not that straightforward. I mean, if it says drink bleach to feel better, they can take it down. That's overtly harmful. But what the anti and questioning sentiments in the vaccine world, they see what's being taken down and have turned a lot of this into seeding doubt and putting out questions. Something's fishy here. You have better experts on the clinical aspect here, but just to give a picture of how many candidates there are and what we should be ready for. I mean, these are early stage, as you can see, it's by the time we get to the finish line, who knows, it'll be a handful, if any. But while there is this phenomena at the same time of vaccine nationalism, of kind of a hoarding of anticipated vaccines for national priorities, there's a lot of south to south deals going on. Indonesia, for instance, has just gotten a commitment of 30 million doses of COVID vaccine from China and the United Arab Emirates, supporting it financially. In India's just bought 100 million doses of vaccine from Russia. You know, this is news about the same week that researchers in Nature were questioning the safety measures and the processes in the Russian vaccine. So there's a lot of things going on in different parts of the world with different vaccines and different negotiations. And this is all around a vaccine we do not have yet, and we don't know what the effectiveness will be. I think we all know that even if we get a vaccine, it won't be a perfect one. And even if we get a few, there may not be enough for all those who need it. So we can't let our guard down on other measures. There's a lot of work going on around therapeutics, but also some of the habits we've learned in this environment, as Asia has taken and almost normalized mask wearing. I mean, I don't think, who knows, but I think consciousness will have to change. The other point, and I just have a couple more slides here, is one of the things that we absolutely need to do with publics in anticipating the COVID vaccine is start to rebuild trust, start to bring some normality back. This has been such a hyper uncertain time, and there are some really basic familiar needs that people have. Basic childhood vaccines, some of the basic health issues that people have not been able to get treatments for, or getting what they need, medicines or vaccines, because of the distancing, because of the stress on system. These are familiar things and really felt needs of the population. The more the system, the health providers can start rebuilding that relationship and building a bit more stability and confidence, it can only help bringing in something new like a COVID vaccine. And then we have something even more tangible, more familiar, and absolutely crucial in the face of COVID is a flu shot. I mean, this is even being proposed and advocated through the World Economic Forum. The good news is in our EU data for 2020, there was a significant increase in publics across all 28 countries, or 27 plus the UK. Absolute increase and a significant one in public perceptions of the importance of a flu vaccine. I think the challenge in our discussions with the EU was hopefully we're ready and have enough vaccines and vials. Pierre, thank you, mentioned my book that looks at my last 10 years of research and some of the stories behind the stories and some of the contextual issues that we need to think about in why are people refusing vaccines. And this is our website, thevaccineconfidence.org, and we're doing a lot on COVID now, even though we're still continuing our regular vaccine confidence monitoring. Thanks so much. Sorry if I hope I didn't run over.
Thank you, Heidi. And we have now perhaps some questions from the audience. To start with the audience, I'm looking if we can have some more light in the audience, that would help. I see one hand in the left, on the left row, yeah.
Hello. I first of all wanted to share a documentary I've been watching last weekend called The Social Dilemma. And I would really recommend everyone in this room to look at this documentary, which is really explaining how social media, you mentioned Facebook, but also all others, cannot distinguish what's reality and what is not, and how fake news is really circulating 6 times faster than real news. And this type of documentary was also showing how anti-vaccine movements were becoming stronger, and also in the COVID context, probably because of all these social media activities. So my question is more linked to vaccine manufacturing, working myself for GSK. What would be your recommendation in this COVID context, how vaccine manufacturing companies should behave for the months coming up? And maybe also not linked to COVID, more in general, does the industry has a role to play in communicating anything on the value of vaccines? Or is that something that authorities and experts have the role to, well, do they have to take the lead in that?
Do you want me to wait for other questions or answer?
If you understood the question, it was clear for you, then you can indeed answer the question.
Okay. Yes, I think it's a really important question. I think that from an industry point of view, promoting the value of vaccines is probably not the role of companies. I think other people should be talking about the value and importance of vaccines. I think from a company perspective, transparency, making information available about the vaccines in clear forms, having some opportunity to, I think also connecting with others. I mean, I think these kinds of promoting the value of vaccines need to be collective, and to team up with universities. I've been doing a big global study with GSK on anticipated willingness of women to be taking more vaccines during pregnancy. So investing in some of the research that helps understand publics. But I do think that, at the end of the day, there is a perception of the black box, how these vaccines are made. Any way that can help people understand better the processes that vaccines go through. I mean, anything that you as a company can make it doesn't have to be hugely complex, but what happens from the beginning to when a vaccine leaves the door? What do you do to make something safe? How do you make sure it's safe? This is something that people just don't know. So basic awareness about the measures taken, I think, would be helpful. But I wouldn't get into the promotional part. Just my view.
Okay, thank you, Heidi. We have one more question in the audience.
Well, I am Leuven Vandermeulen from EBB, the Pharmacists Federation, and I have a very real-time question. There's a balance to be made between confidence and wanting, agreeing to be vaccinated, and availability. Actually, right now, that's an issue, and will be for flu vaccines, but it will be even more of an issue next year when we are talking about COVID vaccination. So how can we manage or balance building trust and confidence and motivate people to get vaccinated, with supply, which will of course be lower than demand in the early stages. That will be a difficult task, I think, next year. It is already now.
Yes, I think one of our challenges is managing expectations, because indeed we are going to have supply challenges. As for the COVID, they've already pre-produced lots of vaccines for the ones that are anticipated to be the more successful ones. And with the flu vaccine, good. So, prioritize, yeah, this issue of prioritizing vaccines, I think what's important for the public to understand what's the criteria. Why is who getting a vaccine and my neighbors not? So I think transparency and processes that are being decided on who gets vaccine and why it won't be, and certainly not all at the same time. So we will get more moving forward to money.
Heidi, we seem to have some sound issues, so I hope we can arrange that. We heard you very well during the presentation, but now the answers to the questions, sometimes we hear you, sometimes we don't hear you. So I'm checking with the technicians. It's a connection at your side, Heidi, so I don't know whether it is due to the internet or whether you can...
I hear you loud and clear.
You can hear us very clear. Okay, now we can hear you too very clear. So maybe if you just part of the answer.
Well, I would think I was talking on the supply issue and managing expectations to make it clear. And I think there has been a good bit of attention to this, but maybe not clear enough just on there won't be enough, assuming we get a vaccine that's safe and effective, what is the criteria for who gets a vaccine and who doesn't. I think it's not just about the decisions being made, but what's the process? What's the reasoning behind it? Publics want to know. As for the flu vaccine, that's a bit different, but I think when you know you have a limited supply, I think publics need to know why certain people have priority. I think it's the more people know early and can anticipate these things, it especially in such a hyper uncertain environment, the better.
Yep, that was very clear.
Are there any new methods under development to tackle down vaccine hesitancy, such as delivering information to schools and teaching students critical thinking? Since all those adults who make decisions for their kids once were children as well, maybe addressing school children might give a generation of parents who are more aware of benefits of vaccines and critical thinking to differentiate between rumor and true news. Thank you.
Well, it's one of the last pages of my book is what I think that's the most important thing. So I fully agree. And I think we should be doing more of it around COVID. I mean, I have a young granddaughter at 6. She's, already knows what to do. I mean, it's amazing how much they know, but to even get vaccines in the conversation, and children. I mean, I think the emerging generation right now, the younger ones who only know, they are much more conscious that not everything is true on the social media, which I think in the honeymoon period when we just had all these novel technologies, there was much less criticalness about what we were looking at. But I think now the problem is people have become so distrusting. I think we also have to, while we're developing critical thinking skills, not breed a generation of skeptics, which is I mean, in terms of not trusting not being able to trust what they read. I apologize, but I need to give another talk in a session. But I'm very happy if anyone wants to contact us, myself or the project, to answer any questions. Thanks very much.
You made it. We're flexible enough to join our meeting today. So good luck with your next talk, and be safe, and we'll be in touch. Okay, thank you.
Thanks so much.
Okay, Sif, do you hear us? Are we connected?
I hear you loud and clearly, and I see you as well. Good to see you, Pierre. How are you?
All right, fantastic. So, it's my pleasure to introduce Sif Nielsen. And I had the pleasure to work with Sif at the World Health Organization at the European Region Office a few years ago. But let me introduce you to Sif Nielsen. She has a master in public health with a very specific focus on behavioral change and social insights. And then she combined that with a degree in journalism and behavior change communications at Rollins School of Public Health, Emory University. Now, her experience ranges from research-based communication with a focus on social insights, qualitative research, to production of tailored interventions, project management, and journalism. So quite broad, but very applied to communication and targeted communication. And at the same time, of course, she has many years of field experience and has been working in many different countries, mainly focusing on public health issues in developing and middle-income countries. Sif joined the regional office in Copenhagen in 2014, working primarily in risk communication, and she is supporting member states in strengthening vaccine acceptance and demand. So, Sif, very happy to have you with us from a distance tonight here in Antwerp, and the floor is yours.
Okay, thank you, Pierre. I just want to share my screen. Can you see it?
We can see it, and if you can put it in presentation mode.
Yeah, you go, but you need... So how does it look like on yours, in your end?
Well, we see the slides, but also at the same time the next one. So it's a bit what you need to see, but not necessarily what we need to see.
Well, it's not a secret. You're going to see it anyways, but let's see. Okay, just...
See you and the slides.
I can maybe stop sharing and then do it again. Just a second.
Don't worry, we all suffer with this.
Oh, okay, I think it's because I have to share this screen instead. How does it look like now?
Yeah. That's perfect.
It's perfect, right? Great. Okay. Learning by doing, I think. So good evening, everyone. I'm pleased to be presenting tonight, and I'm also very much looking forward to going through this presentation. I have to say the latest comment from one of the audience about targeting children making sure to enhance children's critical thinking and building resilience among children actually very much lay the ground for this presentation I'm going to go through this evening. So the question was, can digital gamification enhance vaccine knowledge in children? I think I would like to start out with basically, is the slide changing? Yes. So basically saying, why is it so important that we want to enhance the knowledge among children on the topic of vaccines and immunization? As you can see on this slide, and I think we all agree, so this is not rocket science and not new science, is that vaccine does save millions of lives every year. Vaccination represents one of the most cost-effective health interventions, and vaccine protects against a number of potential life-threatening diseases. We all know that, and of course, thanks to vaccination, we have almost eradicated one of the vaccine-preventable diseases, polio. But still, there's an estimate 1.5 million people that die of vaccine-preventable diseases every year, which indicate that we can do better. On top of that, as what Heidi Larsen mentioned, we still see hesitancy as a factor that contributes to suboptimal vaccine coverage. I though have to say that vaccine hesitancy is not the only reason for low uptake. It's much more complex, and it's also structural issues, such as some communities simply do not have access to the vaccine. It might be difficult for parents to take their children for vaccination, and so on and so forth. I will not go into detail, but that was just for you to know. However, even though that we have had a large spectrum of intervention implemented at a global, a regional, national, and even local level, we still see hesitancy. We still see misinformation and rumors on vaccines, safety, on immunization, which really indicates a need for a much more resilient population. We need to focus on how can we support children and be much more critical of the information they receive. I mean, nowadays, it's like online information. It's not only, surfing on the internet, it's also all the apps that children, they have on their phones. They get notification, information pops up. So it's unavoidable that this topic also reaches children. So this actually indicates a need for a tailored intervention based on a bit more innovative approaches. And that's also something that we have heard from member states. So maybe we should look at a bit longer term investment case here. I mean, one where the future generation are more resilient to misinformation and rumors. Maybe one where future generations become more empowered to make a healthy choice. And maybe also an intervention that goes beyond the health sector. So I would argue, why not go back to school? Again, this is not new, but we know that schools does provide a unique opportunity to reach children. And not only the children, it's actually also the families and the entire community. I'm sure that most of you, or many of you, if you don't have children yourself, you can recall from when you went to school, primary school, that the topics you were introduced to during a school day, often that was the topic discussed over dinner, at home, with your parents, with your caretakers. So it does have an influence what you're presented with at school. And we also know that that information you receive through schools often have like an effect on positive, healthy behavior. So this could also mean that this can offer an opportunity to actually increase the understanding of immunization at an early age, as well as building this foundation for vaccine acceptance in the future. I can give you an example from when I went to primary school. I do remember that we did have a topic on, make sure to save water. I mean, so when you brush your teeth, turn off the water hose or turn off the electric light. And I remember I went back and that was something that I had to teach my parents. And maybe there was not an immediate behavior change, but I have to say now as an adult person, I constantly, turn off the water while brushing teeth. I constantly turn off the light if I don't need it. And that's something that, was introduced at an early age, but at an age where I was able to understand the importance of this topic. Promoting a healthy lifestyle at schools is not new, not at all. As part of many curriculums, we see the topic food safety, we see the topic environmental and health, reproductive health, physical activity, topics focusing on alcohol, anti-smoking, and so on and so forth. And evidence clearly show that tackling these topics at schools as a multi-component intervention actually leads to behavior change. For example, we know that there is a strong correlation between being physical active at schools and then also being physical active in adulthood. So it seems as having a health topic, part of an already existing school curricula, actually might be able to make a difference and to motivate a behavior change, not necessarily the day after, but then at the longer term. But what about immunization? Why is vaccination and immunization not part of the standard health curricula yet, now that we know the importance of it? I mean, we could argue that a lot of the vaccine preventable diseases have become, luckily, so rare that we don't see them anymore in most part of the world. And children, in regards to vaccination, might not be the primary decision making. They still, rely on their parents taking them for vaccination. It's the parents who decides on your behalf. I mean, first of all, the vaccines are given at a very early stage, as recently when you were born. And on top of that, immunization may be considered a bit too controversial topic to be taught at schools. Evidence clearly shows that some teachers actually do not feel comfortable talking about vaccination and immunization because they know that there is a lot of misinformation circulating and they would be afraid of being seen as someone promoting vaccine. And then if something happened, we are aware that AFI can occur, then they would be afraid of being blamed. So, but there are many good reasons for adding immunization to the health curricula. Of course, as mentioned, it saves lives, but also children actually do often remember being vaccinated. So it's an experience that, it might hurt a bit, but the children actually don't know exactly why they're going for this vaccine. The parents might not even know why. So it is something that is rememberable. Top of that, children, they will become future parents. They will one day decide whether or not to vaccinate their own children. Targeting school, as mentioned, will include the wider communities. And on top of that, vaccination is slightly different from all the other health topics mentioned, such as alcohol, drug, healthy diet, and so on, because vaccination immunization is also a social responsibility through the herd immunity effect. So it's not only about you as an individual, it's also taking care of your friends, your peers, your family, and so on. And I think we are now in a situation where it's a good example of, even though that we see fewer outbreaks, they will occur. So we have the COVID-19 pandemic. I mean, and why does children not deserve to know what this is all about? Information is all over, and they should also be able to understand and digest the information that they hear, so they are part of this decision-making process. Okay, so far so good. We know that schools are important. We know that adding a health topic to an already existing school module does potentially have an effect on behavioral change in the future. But when that is said, evidence shows that it's not enough just to convey knowledge to be able to see a behavior change. Interventions need to be combined with other activities. So we have to look for an all-comprehensive approach that needs to engage your children. It needs to engage your peers and the community in a different way that we have normally seen in school settings. So here's where the gamification part comes into the picture. Why gamification? It's because it's experience learning that is much more effective than a secondhand knowledge. So what is meant by that? It means that if you can create some kind of environment where you feel part of it, instead of just a teacher delivering, information, and then it's up to you how to digest it and how to analyze it. Here, a game-based learning approach actually does make it possible for you to convey the knowledge into practical knowledge. So it's literally a learning by doing. It's creating this sandbox environment where you as a student or pupil can try out things without being afraid of failure. On top of that, gamification has been framed as a promising new alternative for a new model for health. And it allows children to learn more than just facts. It's a different way of seeing and understanding problems, so they can approach problem solving from a different and a new angle. So this is just to give you a short insight into what the evidence is out there already now. And we know from literature review that the current state of evidence supports that gamification or game-based learning can have a positive impact on health and well-being, particularly for health behavior. So below you see a few examples that's also based on evidence that we know that video games can positively impact the problem-solving skills. And we also know that teachers find the gamification that it creates a positive environment among teachers and students, and in that way also encourage for, a knowledge uptake. But of course, more evidence is needed, and particularly for, the game-based learning on immunization. Which lead me to the fact that we have actually developed a game-based educational package on immunization and vaccination. It's called the Immune Patrol. And why did we develop that? So really we want to add the topic of vaccination to an already existing health curricula for the reason that I just mentioned. We want to utilize the school settings and the particular age group, so in this case, 10 to 12 years old, for the health information. And of course, then we also want to promote and motivate this health-seeking behavior through gamification. On top of that, we would like to provide the teachers with an easy plug-and-play platform, a platform where they have all the needed information for them to be able to run a good educational process on this topic. So basically using this platform for them to say, this is information provided by WHO. It's not something that I have done in my spare time doing research and then I'm now analyzing the information. This is really based on evidence-based information. So it makes the teachers feel comfortable basically deliver this package as it is. And of course, we also want to convey source criticism skills. And that's a part of this educational package as well. And that was something that was mentioned by the audience. So what is the end outcome of this? Of course, ultimately, we would like to create a more resilient community where everyone sees vaccination as an important ingredient of basically leading or living a healthy lifestyle. So what is the next step? I mean, from our end, so the Immune Patrol was actually pilot tested in 2 countries in 2019. However, of course, based on this, we can see that we need to adjust the package slightly. And now, when that is done, we will try and pilot test, and not only that, but also evaluate the game in additional member states. And one thing we know is that one thing is whether this might encourage the behavior change, but we have to seek more evidence into whether the gamification part of it has a huge difference. And that we'll have to do by actually testing and evaluating whether the against having like case control, whether the gamification intervention next to the non-gamification does make a difference. And that's what we're going to do in 2021. So that was all from my end. So thank you so much. And now I think it's, we still do have some minutes for questions. I'm happy to answer them. Thank you, everyone.
Yes, thank you. Thank you, Sif. And we have to be honest, this was really teamwork with a lot of people, multidisciplinary people. And that is, of course, also quite important to come to such an achievement. Okay, let's look at the questions from the audience first. Do someone wants to ask a question to Sif? I don't see any finger so far. As you said, indeed, the last question from the previous session was exactly a question for you. So I don't know whether you want to add something to that question, because that was really whether we had tools to educate students, to educate pupils regarding the importance of immunization. And I think what you show here is already part of it. So I don't know whether you want to add something to that question.
No, I think what the important part here is, and especially when we're talking about vaccines and immunization, is of course that we create the package in a way that teachers they do feel comfortable actually delivering this curriculum. Because you know, I was mentioned also during Heidi's presentation. I mean, there is still vaccine hesitancy. There is still a lot of misinformation out there, and of course. Then also as part of this, it's really, you know, trying to, how do you say, further enhance the children's skill sets within this critical thinking, and especially on vaccinations and immunization. So I think that's one thing, and I think that's of course the challenge that we are facing now. Whether that's at all possible to do. I have to say the evaluation we did in Ukraine looks extremely promising. And some of the feedback that we got from the teachers was exactly that they did not have to interpret information themselves, which they have to do for some other health topics. So then they have to search online and especially within this topic, they do find that extremely difficult and challenging. So they did find this package extremely useful because they could always refer to and say this is information which is nuanced and evidence-based and has been developed by a well-known organization, so in this case WHO.
Sure, thank you. We have a question also from the people at home who follow us. Is there a correlation between being stuck or game over in a certain level in the game and a bad connotation about a topic, in this case, vaccination for children?
So whether there is a correlation, so it's specific into the immune patrol, or maybe you can repeat it again.
Specific for the game immune control. So is there a correlation between game over in a certain level of the game and the bad connotation about the vaccination for children?
Okay, so basically the way this has been, the way as it is now, it's and the way gamification actually works is not necessarily that you will face this game over, or you will see, you know, how do you say, large consequences. That's actually not the idea with gamification. So it's actually a good question. So gamification is all about motivating and engaging the children. The gamification part of it is, of course, the credit. So if you do well, in this case, you get some credits for you to be able to build up a strong army, for you to be able to protect your avatar, basically. And you will, how do you say, if you're not able to do the arcade game well, then you might end up at hospital, saying that, okay, I mean, now you have to do better. You need to go to hospital and be treated because you are not able to support your immune system in that way. But then module 2 and year 6 starts from scratch again. So it's not that we'll end up leaving out like one group of students, for sure not. So there's constantly this motivation of then just doing better the next time.
Great. Perhaps you can also tell us, this consists of a series of 6 lessons. Can you give a little bit more details on the lessons, the topic of each lesson?
Yeah, exactly. So you're right. As it is now, it consists of 6 different lessons, and one is in general on the immune system, and one is on vaccines. What happens when you actually get an injection or get a droplet? How does your immune system respond to it? Then we also have a topic on disease outbreaks and herd immunity. So we have something called the infection school, and that's what I mentioned. That's for the children to understand that this is not only you to protect yourself, it's actually also the wider community or your peers or your friends. If you don't get vaccinated, there's also people out there that actually for any other reasons cannot be vaccinated. That could be due to underlying health conditions and so on and so forth. So that's another thing. And then we also have a module on vaccine development, which actually ties quite well to the COVID-19 situation and what was discussed earlier this evening, that it's important for the children to understand that vaccines does go through a thorough testing and is not just all about for a pharmaceutical company to, own as much as possible. We do have instances such as WHO who oversee this process, and when it's introduced in a country, it's still being observed, and if in any case there should be an issue, then that will be reported back. So that's another thing. And then, as mentioned, the critical thinking of it. So the source criticism, we do find that extremely important. How can children be better in how do you say, identifying which sources are trustful and not? So we have a module on that as well. And for next step, we will actually add a COVID-19 module to this package as well. So that would be more as an annex. So if some schools find this relevant as part of the curricula, then they can add that topic as well.
Wonderful, thank you. I have another question from the audience at home, saying that, as you mentioned, a good age to target is the pupils between 10 and 12 via school. Do you also target older children, like 12 to 15 years, and especially the ones following vocational education? Because these are the ones that are hard to convince regarding all type of health education. It might also belong to the non-believers. So are there specific efforts made to reach and target pupils at vocational education or within vocational education?
So the short short answer to this question would be, in this case, no. However, the reason that we are targeting 10 to 12 years old, as I said, is because that age group, they are, just that age where they do understand that they're part of a greater society. So it's not all about them as an individual. However, they are not how do you say, at that age group, so more than 12, we talk about 13 to 14, where they are way too critical. And that needs a total different approach than what we have developed with this immune patrol. So the age 10 to 12 is where you can deliver, how do you say, a nuanced information about the health topic without them having to be, too critical. But it's an easy way for them to adjust some knowledge, digest some knowledge. So when that is said, so if we target the 10 to 12 years, then we are already, how do you say, at the forefront in regards to the elder children. So that's actually the purpose of targeting exactly the 10 to 12 years old, instead of trying only to tackle or targeting the elder ones. That could be a combination for sure, but that was the reason why we ended up with 10 to 12 over.
Joseph, I have 2 questions in the audience. The lady in red.
Did you assess if these children talk with their parents about the game, and so if the message is spilling over to the elder people or to at least their parents?
Good question. Thank you so much. Actually, that's something we're going to assess in this upcoming evaluation, because that's something that is extremely relevant and important for us, whether we do have an influence on the wider community. So in this case, where I did the small-scale evaluation in Ukraine, that did not, how do you say, go as a one of the clear evidence based conclusion, but that's something that we'll seek into when we do it in additional member states. So the data that we receive is much stronger, and we'll be able to conclude something.
Yes, so I had a question, long term, how do you plan to implement this? Would this be like open source? Would it go through the school systems? What's the idea there?
So actually, both ways. It will be an open source, so everyone can access it as soon as it's been, how do you say, final. So we still need to adjust it a bit. So in that way, open source, everyone can use it. It can also be used outside the school setting. Of course, then we'll do a bit of groundwork and try to actually implement it, which is, of course, the main objective, to implement it as part of an already existing health curricula in schools. And we know that there are different curriculum out there where it could feed in, but of course that needs to be then, how do you say, implemented at a particular level, so through the Ministry of Education. For instance, in Ukraine, where it's tested, the Ministry of Education already reached out again and said that they want to have this module as part of their main curriculum in school. So somehow it has had a positive impact by just introducing it in, like, I think it was 20 or 40 different schools in Ukraine. Yeah.
And one more question here among our panel members.
Thanks.
So, Pierre.
Sif, that's very interesting and really great work. I have 2 very practical questions. One, is it translated in the many European languages? And second, how long does it take to do the 6 lessons altogether?
Again, 2 very good questions. First of all, we will be able to translate this into 53 language, basically, for all our member states. As it is now, it will be translated as when countries, basically raise an interest, and then that will be translated. So, but it's developed, so it's extremely easy to actually translate the, how to say, the context that is already in the game. So that's one thing that we're very aware of that needs to be done quickly, and it can actually be done quite quickly because how the system is set up is really just like an Excel spreadsheet. So that was for question 1. As it is now, it's 6 modules, and that's something that will be changed. And as it is now, they have to go through lesson 1 throughout lesson 6. So in the new game, which will be introduced in the beginning of 2021, it will be, how do you say, a game that the teacher can actually modify him or herself. So if they just have a short gap, or maybe they have a theme week where they can introduce this topic, then they can do it. So it fits their context basically. But to reply your question directly, as it is now, consists of 6 modules and 90 minutes each. And that will now be changed to, maybe less modules and only 45 minutes each. And then it will be up to the teacher to actually customize the educational package so it fits into their curriculum. I also have to say that it's the way it's been developed is that it fits into different subject matters. So that could either be language, or that could be geography, that could be, for instance, the outbreak session, the critical thinking part of it, and also the math part of it. So you can go together with different subject teachers and also introduce this. So it's quite, how do you say, adjustable, and in every context, whether we are in the rural part of Kazakhstan or in the UK, it will fit into the health curriculum, the way the curriculum is set up in a specific context. Over.
All very promising for the near future, and we are all looking forward to it, to be honest. I see a lot of enthusiast faces here on the platform and in the audience. So this sounds really great. On behalf of the organizers, I really would like to thank you for your participation at this hour. I know you probably have to put your children, in particular the twins, in bed. So wish you all the best, a good evening, and if you want to stay connected, please do so. And now we will move.
Thank you so much, and good evening to you as well.
We will move to our panel. And within our panel, we do have 2 gentlemen and 2 ladies. And I will start by presenting our 2 gentlemen. So we have Professor Dr. Mark Raas, the former head of the pediatric department at Jessa Hospital in Hasselt, and president of the Belgian Society of Pediatrics. And also Professor Dr. Pierre Meesters, head of the pediatric department and director at Molecular Bacteriology Lab from the Queen Fabiola Children's University Hospital at the Free University of Brussels.
And then next to Pierre Meesters is Dr. Veerle Vekeman. She is working at Kind en Gezin, where she's responsible for many different medical topics, and vaccination is one of these topics. And our last member of the panel is Dr. Katlijn van Hoek. She is the scientific coordinator of the Flemish Society of Youth Healthcare, and the Flemish Society of Youth Healthcare is responsible for writing guidelines for the school health services, or the CLB's, the Centra voor Leerlingenbegeleiding. And amongst those guidelines are also guidelines on vaccines and prophylaxis of infectious diseases. So welcome everyone. Yeah. Okay.
So we start with a number of questions that we prepared or that were sent in advance. So one of these questions is for our colleague pediatricians. How do, I would say, GPs and pediatricians feel more comfortable if they would get questions related to vaccination? What would help? How can we try to improve this the comfort zone of GPs and pediatricians? What would you suggest?
Well, I can answer as a general pediatrician and working in a private practice also in a regional hospital in Hasselt. Can I have a case? 2 days ago, I had a call phone from a colleague of me. She had an infant of 4 months old, and after the second injection, so at the age of 3 months, so with the hexavalent vaccine, she saw a local reaction and also a rash, and it showed urticarial rash on the lower lip. Fourth vaccination, the same question, the same problem, 2 injections, left and right, and she saw after some hours urticarial rash on the whole body. She asked me, what do I have to do next time? What do you think what could have been happened? Is this an allergic reaction? Is it a hypersensitive reaction? Is this by the fever? So she asked me that because she thought I had some knowledge about vaccines, but I had not a straightforward answer. So my question is, can I have somebody to answer me this question on a very quick? Tomorrow the parents will call you, and do you know what the problem was? So for me it would be very practical as a general pediatrician to have some approach to a committee or a person or to have a quick question. So this would be very practical for me to have an approach to that kind of answers about my questions.
So, and what did you answer in the meantime? Because I'm sure the audience won't.
I can give my answer, but it can be wrong. But the experts are in the room, and I think it's not a kind of allergic reaction, but a kind of hyperreactivity of this child with fever. But having an urticarial rash is not so common, I think. And I have made the proposal to give the vaccine at the age of 15 months and also at 12 months, because it was also a pneumococcal vaccine involved in it. But I don't think it's the right proposal. But what we did in the past with the measles vaccines, we did a skin prick test. I don't know if you agree that we can do it, or if you think it's needed to do it, but that was my answer. So it's up to you if my answer was right, yes or no. But these are the practical problems that we are dealing with.
What do you think? To have GPs and pediatricians feel more comfortable?
You have to answer my questions first.
I think it's right. But what I think it's complicated. It's changing all the time. The vaccines are changing, the schedule is changing, epidemiology is changing. So I think it's a difficult task for GPs and pediatricians, even for us who lives all days in vaccines. It's not always easy. So I can see that there is a real difficulty. And my feeling is that maybe we should have both ways, that, they must be able to ask their question, and we as a community need to organize ourselves to answer systematically in the Valentine Day or these kind of things, but also in a more, very quick and fast. I have the consultation tomorrow, should I get my answer? And at least in my community, we don't have this in place. And I think that's probably at some stage political investment in making, resources available for that. But in the other time, there is also need to permanent education and update and continue medical education that probably should focus a bit more on vaccination, and it needs to go both sides.
I also think they always say, look at the website of this and the website. No, I have to get the information actively. So a newsletter or every 3 months or 4 months with some practical, your questions or mine questions, so we can learn from each other, and we can have regularly why not, published by a trustful society where people are believing in. So that could be the other way around, that I get it on my computer. Oh, okay.
And often the information is somewhere, but to find it in a nicely friendly environment and fast, that's not the way.
No, we are busy. Everybody is busy, but when I have it on my desktop, I have it.
Pierre, what about the efforts that you do at the Well Baby Clinic organization, the Kinderen Gezin, in terms of keeping your doctors and nurses educated, aware, informed?
Yes. Like the colleague said, it's complicated nowadays. So I think also the discourse on vaccines has been complicated. So parents, they do ask many questions. So at the one side you have the vaccine hesitancy, and it's much more than some topics like autism and so on. And on the other side you have the complication of catch-up schedules and new vaccines and so on. So I think that all vaccinators should have the access to quick information. And so in Kinderen Gezin we have our own database, and we give some newsletters to our nurses and doctors also with some new information. We also, last year, end 2018, we started with those workshops about vaccine hesitancy. We developed it in partnership with Corinne. So because the questions were coming because of the measles were rising in Europe and all those epidemics. And then we started to train them, so they are more capable. They have to have the ability to answer the questions. So we work on several levels. We also have some information on the website that's accessible for everybody, for the parents, also for our doctors and nurses. And we think that our doctors, yes, it's maybe not fast enough, not accessible enough. So they have their consultation 15 minutes. They have some problems. They have to search the. Maybe there should be a call center. I don't know, like the COVID call center now. But I think we have to think about that. Yes, in Kinderen Gezin, you can work at a level on vaccine hesitancy, but it's all together. It's one package. I think that we should think about. Yes, maybe.
What about the youth health? Kathleen, Corinne, you're both involved in youth health.
Situation is a bit different as we see children for vaccination alone without their parents. They're a bit older, so the side effects are less impressive. But it happens, and then of course phone rings and you have to give an answer. We try as a scientific society to deliver information on a website. We have some newsletters, but I have to confess on vaccination it's not so often. And I think the problem of having at the moment the needed information is more needed for smaller children, I think, and less in school children.
Okay.
Can I add something? I think that we also have to coordinate a little bit what you are doing, what we are doing, and giving the same information. We as pediatricians, with the family doctors, we have to announce the same messages and to work together, because you have your newsletter, we have our newsletter. It will be more practical
and not only on vaccination, on prevention as a whole.
And everything.
Be coordinated.
On healthcare.
Yes.
Yeah.
Okay, I switch to Corinne for the next question, and then I can take off my mask. Because we agreed that here we are at least 1.5 meters from each other, so that should work.
Okay, so the question, can I just reply also first to the
with pleasure.
or ask another question? So
I know currently you have the pediatric COVID task force that is, I think, working very well. It's Belgian pediatrician who work together to combine the information, inform each other, and then from there the information is spread to different. And I was wondering, is this something similar that you would think would be useful to have, but then just regarding vaccination?
Yeah.
It's
Sure, I think we agree about that. About everything.
and then it can
But
be.
We only give advice. Huh? We don't have guidelines. No, we give our when we get the question, we try to answer it on a scientific and as possible evidence-based way. That's the only thing that we about masks, about testing, about tracing, and so, and that's it. And then we give it to the demanders, and they can do.
But
what they want
if we would bring together a team that can actually answer the questions, where within the team also, if you get a question, you can check for yourself. Maybe okay, this is the question I got. This is my answer. Do you agree? Because I think it cannot be a one person task. It's a task force would be I think, if I listen carefully, something that maybe Flanders Vaccine can.
But maybe one of the weaknesses that we've been doing that, with the sense of emergency, and I think it has been a really great success. But it's on top of all the rest. It's not, time and people dedicated to this. It's the same people who do other things. And so I think it's manageable for a certain time. I'm not sure it's manageable forever. So, but the principles are there.
I think then we should look to, I think Switzerland and France, they have similar task force groups.
If we could have some support, secretary support or something else, it would be kind of a help also. But,
okay. Then maybe, I don't know whether there are questions from the audience, or maybe the audience would like to add to.
A quick reaction to the discussion about having access to new science and evidence to support practice. There is, and I happen to be an administrator of this non-profit organization that organizes the dissemination of evidence-based practice guidelines called EB PracticeNet. It is funded by the state, but very little. So there is some support, some administration support, some IT support, and guidelines from abroad are being translated. It's not specific for vaccines, but I think we should have a collaborative effort for evidence-based practice support, not just for vaccines or for pediatrics or antibiotics or pharmacists, but a collaborative effort. And there's loads of work to do there, and I also think that the resources available, which are of course limited, it's not just hours and doing things on top of, also the funding is limited. So collaborative efforts to have good evidence-based practice support in Belgium in an international collaboration is a way forward.
Other questions or additions? Or no? Okay, maybe the next question is about, we're all hearing about vaccine hesitancy. We're reading all these kind of comments on the internet, and we have a feeling that vaccine hesitancy is rising. I think pediatricians, GPs, and also within Kind en Gezin, the number of parents with questions is rising. And the question is, do we need actually regular measurements to see in which direction we are going, and how do we need to adapt our communication?
it could be interesting to know what is living in the world and in the world of vaccination also. But I had another proposition, like we said, we need some answers about some complications of the vaccination. Also, I would be interested is having answers about hesitancy problems, and you can also put that in a newsletter. Some tips that you actively distribute to me or to anybody. How do I handle this or that question? The questions can be collected, and then we give an answer, and you send it out to the practitioners. We are not the great vaccinators in Flanders and Walloon. It's our kindergartens in ONA, but we see people, and they ask us about questions, and they spread out their fear. Also the family doctors are calling us for a new vaccine, and so how do I handle that? The swing population. Can I convince them to do it? And it would be very practical for me to have some tips. How do I have to react about it?
And then, do you think we should take these questionnaires from the parents or from the healthcare workers who are providing the vaccines and are confronted with the questions?
Both, I think.
Yeah, both.
But what I also have as a problem is, how can I, as a clinician, physician, reassure that when I give some data, that these data are believable? Do you have a tip or a suggestion to be as convincible as you have to be? Well, you say it, but is it the source where you get your information? Is it the person who is telling you the truth or the non-truth thing? So that's not always easy. We have seen a slide, I need data, but do the people or your clients trust you when you say it's this or that? Perhaps there are some ways that I can be more convincible than...
I don't know how many of you are aware of this increasing situation where facts are checked. And on the news side of the VRT, you have the fact checker, which is quite interesting. And you also have now some newspapers who systematically have this kind of fact checker. I think that also helps already to check a number of data to see whether they exist, whether what circulates is yes or no, is true or maybe true or completely wrong. I think increasingly people want to know that and want to check it, and I think that's also our role to help them to find this information. I don't know how many people in the audience know the website Gezondheid en Wetenschap. Please raise your hand and don't be shy. There is a very specific topic on vaccines where you can find a lot of Q&As, more than 30 in the meantime, also addressing the typically hesitant questions or questions from hesitant parents. So I think we really have to help people to find this, because it's worded in a way that is not too scientific, that it is not too complicated, so that it is accessible. So, but I think indeed we have to help each other to find that information. It's there, but we have to find it, to make it much more known. Yeah.
Corinne, I heard you a few times explaining reasons or parents express concerning their hesitancy. It's so interesting. So I think if you cut your presentation in small leaflets, it's very accessible, the way you explain it. So it's all there for parents, for us.
Yes, I agree. I think also that an important part of solving the problem of vaccine hesitancy is that parents with questions, they get reliable answers from experts. So, and we know that they trust their healthcare providers. So I think they are in between, because we have to get the science to those who benefit from the vaccines, and we are in between as doctors, as nurses. And I think it's important that we sit all together to achieve that all those healthcare providers become experts in an easy way. so they don't have to study very long time, but that they have that easy access, so that it can give reliable answers that are evidence-based. And I think we should work all together on that issue.
So your website is accessible for all healthcare workers, for all parents?
Yes, at 2 levels we have all the information for the parents. It's accessible for everybody, but we still have some closed information that we just give at our. Maybe we should disclose. How do you say? Open that to everybody. But this
open
is more
access,
yes, open access. This is more for the healthcare providers themselves. So it's not so easy to understand, and also. But maybe we should do that. Maybe we should make it together on a higher level from the government and put it, like gezondheid en wetenschap. You can find a lot of answers, but maybe not enough. It's a start.
Yep.
I think, but it should grow to something that is, more
in a concerted action. Yeah. Elisabeth. Birchman was just gone.
So, well, of course, there are many websites available from different sites, but I think the problem that we are facing now is more and more coming from social media. That's really where you have all the fake news circulating, and unfortunately, especially I think the younger generation, they are not looking anymore at the journal on TV. They are not looking anymore at journals, the daily journals. They are informing themselves out of social media, and people are so much convinced of what they read there, and because it's always reinforced as well. And the question is, do we monitor social media? Do we do anything about this? I know it's not just a local problem we can handle, it's probably more a global problem, but what do we do about that? Because that's really, I think, where the problem comes from.
That's part, of course, of what some countries do, but not many, is the kind of surveillance of what is circulating, kind of barometer. You can survey parents and healthcare workers, but you can also survey the information that is circulating, in particular the social media, and try to prepare them, because that belongs to the preparedness of a country or the preparedness of your healthcare workers, that if you know that something circulates, you can also start to tailor the information and put it on a common website. So I think it makes sense really to see and watch what is circulating. Is it a certain adverse event? Is it a fake news? But then you need also to prepare your GPs, your pediatricians, your vaccinators to really know the answer in a very rapid way. So that's, I think that makes sense, and it makes part of a overall plan to be ready. Something we have to learn with the COVID-19 situation.
I think we need a vaccine influencer also. We need vaccine influencers also, I think, TikTok and so on.
Yes, I also think that the determinants of vaccine hesitancy, we see that it's dependent from country to country. It's different from region to region. And it would be interesting to monitor it also for Belgium or Flanders. On the other hand, I think that those last months, vaccine hesitancy is a really hot topic in the press, and there is circulating a lot of things on internet, but at Kind en Gezin we don't see it yet. So I have been looking at data for the first 6 months of this year, and it stays stable. So we see less than 1% of the parents that really refuse or hesitate for a vaccine. So the amount of children that get Emovax, polio, those are refusing the other vaccine. So that is staying stable. I don't say that the questions aren't raising, and they are doubting, But we have a strong system, of course. We reach more than 90%, and our strong system is that we have the face-to-face contacts, sometimes at the end of the pregnancy, not all of them, but in the beginning after the birth. And so then our people, our nurses and doctors, they listen to the questions, and so we give the tip that also the parents who have read everything, they have to check the websites, and we learn them, like you said, what is that website, who wrote it, are there any reliable links, check the links of the website. So I think a lot of people, a lot of parents don't have any questions, and they agree with the vaccination, so it's only a small amount that have heard something. And then we have that strong system for our people who can explain and take some time and sit down and listen to the parents. And then the parents, they relax, and we can convince them. So I think in the group that is hesitant, of 20–25%, a lot of them we can convince to vaccinate. And then we have that small group, 1%, they are so strongly against vaccines that it's no use. So that we only give the information on the mandatory polio vaccine, and then we can't do anything else.
So maybe we need games or Facebook, Twitter, and because the more stupid it is, the more viral it becomes. I mean, some of the stories around COVID-19 are just unbelievable, and people believe it or not, I'm not sure, at least they share it. And so there is a larger education problem that goes behind the vaccination, I think.
It's about health literacy. In fact, it's health literacy. And it should start indeed in school, and be strong there, and then you can build up when they are adults, they have children. But yes.
Can I say something about schools? I agree that we have to focus on vaccination, but we have to focus on prevention.
Yes,
and
not only vaccination.
No. You have to breastfeed your infant when you're pregnant, when you have a child. You have to. You may not smoke. You have to be put on your helmet when you're in the traffic. You have to see that you are eating healthy. So. When you are incorporated in a preventive program, a package, not only vaccinations, it has to be the noblest way of getting vaccinations, because the other things are also healthy, and so we have to compare a little bit and to launch it with the other measurements. And I think that the effect could be, it's logical that you have to vaccinate, because you also have to give breastfeeding and so on. So it may not be focused only on vaccinations. We have to embed it in
well, it isn't. In the educational outcomes, there is a package on society and health. Yeah. And prevention is there focused on food, physical activity and hygiene. So vaccination can have a place in this.
It has to be the noblest thing in the world.
Yeah.
Yeah, but it should be in a pleasant way, because those anti-vaccination groups, they use social media and they use images with very strong emotions, and they spread doubt and so on. But we also see that the positive messages on vaccines is mostly very boring, or like statistics, or yes, it's not in a pleasant way. So I think we should think about using that media, social media, Facebook, to spread very nice things about vaccines and prevention and all of that, but in a way that is that is attractive. I think this is very important.
These games that you saw are a way to be attractive. You can play with it. There are several layers, because the person who calls TC, T-cell, is Theophil Cornelius. So he has also a name. So you can use the name, you can use TC, you can use T-cell depending on where you are in the game. So there are several levels to teach. But I fully agree, we shouldn't be too dry, too scientific to bring over the message, too many data. We just have to use very good examples to show that it works, that there is an impact, that we are moving forward. But that is requesting quite a lot of communication skills. Okay, other question, Corinne.
I have a comment from the audience at home. So with this, I also want to invite the people at home to write other comments or questions. So we got a comment from, I don't know who, Kovac. So I'm absolutely in favor of very strict monitoring. Hesitancy against influenza vaccination seems to slow down under the influence of the COVID-19 and stimulate the willingness to vaccination with many persons at risk before never asking or open for vaccination. So it can change relatively quickly under the pressure of circumstances. So very conscious monitoring could be very helpful. And I agree, I think it can help to target the message that we want to give, depending on the concerns of the parents that are circulating or the stories that are circulating on the internet, because history has shown that it can really shift the way, especially in America, where at the beginning the focus was really on the adverse events or adverse reactions upon vaccination. Now it's more like I am the parent of this child and the government should not tell me what to do, and so I want to make the choice about vaccination for my child, but this requires an entirely different answer or entirely different communication than when you have a parent who is concerned about the safety of the vaccine. And so I agree that monitoring is really important to be able to respond in a correct way to the concerns that are circulating on the internet. But having said that, I have to say, in preparation of this meeting, I was looking for fake news of vaccines and COVID, and I found it really hard nowadays. So if you type in Google, and you are actually guided towards official websites, WHO, CDC, and so it's I was really surprised to see, and it was really very hard. And even on Facebook, I thought, let's dive into the anti-vax groups. But again, there, so things are moving, things are changing, I have the impression. Yeah.
But on Twitter, we have a whole collection, if you
need I agree.
All right.
Okay.
Yeah. Okay, we heard that well, just imagine there would be a COVID-19 vaccine. It will be important to have a high immunization coverage at that moment. Do we have to make immunization against COVID-19 mandatory, yes or no? This is the 1 billion question. But of course, this is a question that has been raised. What do you think? Pierre?
No.
I think you had to answer this question already several times. So your point of view is no, mine as well, to be honest. But what can we do to guarantee a high immunization coverage with a new vaccine? Of which some people say it has been developed in an accelerated way. I prefer to say it has been developed in a prioritized way.
And in a collaborative way.
Yeah.
I think, I mean, the data we got from AD and others shows that, I mean, it was small on the slide, but around 75% in Belgium would agree to vaccinate themselves. And that's probably more than the vaccine we will have, at least for a few months. So that's a bit, it's a very practical point of view, but do we really need to take a big hammer if we don't have enough vaccine? And if anyway, we will tailor it to some high-risk groups, and then, you know, and then there is the whole question about where will we be and where do we have to go in terms of immunity and collective immunity, and there are many, many controversies around that, but nobody really have an answer as far as I know. So that's a short answer, but other opinion?
All in agreement with that?
Yeah, no.
I think it will be difficult when you see the survey in Artsenkrant. When you ask the physicians themselves, should you immunize yourself? 1/3 said no, I think. So if we are not convinced, how could you put it as a mandatory measure to the people? So it starts with us, I think.
Yes, and maybe also in countries where they have mandatory schedules, it doesn't mean that they have high vaccination rates. So I don't know, maybe Corinne, but I think it's not a guarantee that you have a high vaccination rate, because people, they don't want, like you said, that the government is deciding for them, because they say it's my child, why can't I decide? Or it's my body, why can't I decide for the COVID vaccine? So, and we see always with the mandatory vaccines that then it grows the anti-vaccination groups, or other groups, they have more resistance.
And then what about mandatory immunization for healthcare worker in ICU?
Make it one of the quality labels of the hospital. And that works. So you don't have to make it mandatory, just say, okay, you need to do it because that's very important in the accreditation of the hospital, in the quality label of the hospital. We really need to reach 90% coverage, and it can work. Yeah.
Some hospitals do that for flu.
Exactly.
Yeah.
Yeah.
Some incentives for the personnel.
Well, that doesn't need to be payment. You know, in Switzerland you get a better parking place if you're vaccinated against flu. But now participating in a soccer game is not easy. It's a lottery. Okay.
Okay, I think we're coming to. We still had some questions, but we're nearing actually the end of our somewhat awkward, but still. Well, we're still in an awkward situation, so the normal immunity for health was not possible, but I will leave Pierre to...
Well, we will first have the closing words of Minister Beke, Minister of Welfare, Public Health, Family and Poverty Reduction, and then I will officially close the meeting. So can we have the message of Minister Beke, who sent a video message? Yeah.
Dames en heren. Ik wil jullie van harte proficiat wensen met de organisatie van dit buitengewoon interessant symposium. Het is mij een echt genoegen dat ik deze bijeenkomst mag afsluiten met een woordje over het belang van vaccinaties in het kader van het preventieve gezondheidsbeleid in Vlaanderen. Immunisatie voorkomt ziekte. Inzetten op de preventie en de sensibilisering hieromtrent is ontzettend belangrijk. Vaccins spelen bij preventie een cruciale rol, maar ook sensibilisering rond vaccins en vaccinaties is absoluut noodzakelijk. Steeds meer duiken de campagnes van de antivaxers op. Het belang van vaccinaties is al vaak gebleken, ook tijdens de coronacrisis nog meer. En toch aarzelen er nog steeds ouders om hun kinderen te vaccineren. Daarom is een goede gezondheidsvoorlichting en een sterke communicatie ook zo belangrijk. Samen moeten we de ondermijning van het vertrouwen in vaccins en vaccinaties tegengaan. De ongegronde vrees voor vaccins en vaccinaties verbeteren. En ervoor zorgen dat we de mensen bewust maken van het belang daarvan. Vaccinaties vormen immers naast de beschikbaarheid van drinkbaar water het middel bij uitstek om infectieziekten terug te dringen. En ze zijn ook het voorbeeld van succes in de preventieve gezondheidszorg. Door systematische vaccinaties zijn we zo bijvoorbeeld in de tweede helft van de vorige eeuw de pokken wereldwijd uitgeroeid bij de mens. De Wereldgezondheidsorganisatie streeft ernaar om ook polio uit te roeien, wat intussen in verschillende regio's in de wereld al is gebeurd. Afrika is onlangs nog poliovrij verklaard. Ook wil de Wereldgezondheidsorganisatie de eliminatie van mazelen en rubella realiseren in Europa. Een blijvende hoge vaccinatiegraad is uiterst belangrijk om dat te kunnen realiseren. Dat is dan ook een van de hoogste prioriteiten binnen het vaccinatieprogramma in Vlaanderen. Waakzaamheid, blijven van vaccineren, zal dan ook absoluut noodzakelijk blijven. Met de huidige epidemie van COVID-19 was het niet eenvoudig om de continuïteit van het vaccinatieprogramma te kunnen realiseren en een hoge vaccinatiegraad te kunnen behouden. Met de lockdown en de sluiting van de scholen zagen in de consultatiebureaus van kind en gezin van opgroeien en de centra voor leerlingenbegeleiding zich genoodzaakt om tijdelijk de geplande vaccinaties op te schorten. Maar in die tijd hebben ze zich gereorganiseerd om zo de achterstand zo veilig en volledig mogelijk te kunnen inhalen. We willen er dan ook zeker van zijn dat er geen extra epidemie van mazelen of kinkhoest zou bijkomen. Maar er zijn ook extra uitdagingen tijdens deze epidemie. Zo werd vanuit Vlaanderen voorgesteld om gefaseerd een griepsvaccinatie bespreekbaar te maken voor dit najaar. En deze vaccinatie wordt ook voor het eerst nu zo gerealiseerd. Wie volgens de Hoge Gezondheidsraad een prioritaire indicatie heeft voor deze vaccinatie, kan in een eerste periode al aan een vaccin geraken. Anderen moeten wachten tot half november. Met deze maatregel willen we de bezetting van de ziekenhuisbedden zo laag mogelijk houden om de nodige ruimte en mankracht te hebben voor de zorg voor COVID-19-patiënten. Voor de residenten van woonzorgcentra wil ik in dezelfde lijn pneumokokkenvaccins voorzien dit najaar. De volgende uitdaging wordt de vaccinatie tegen het coronavirus. Het zal een moeilijke oefening worden om de doelgroepen gefaseerd te kunnen vaccineren. Uitdagingen genoeg voor de komende periode, wat de implementatie van het vaccinatieprogramma betreft. Toch zullen we preventie en sensibilisering ten alle tijden van onschatbare waarde blijven vinden voor onze maatschappij. Hopelijk kan u met het coronavaccin ons snel vooruit helpen en kunnen we stilaan ook teruggaan richting de normale gang van leven. Daar kijkt iedereen ongelooflijk naar uit. Bedankt.
Okay, so let me try to conclude on what we have heard today. You know, there is quite a nice parallel between COVID-19 and vaccine hesitancy, and that's the 3 C's. For COVID-19, as you know, you have the closed spaces, the crowded spaces, and the close contacts, 3 times C. And here we heard today, we have the convenience, the complacency, and the confidence. And that makes, of course, the whole vaccine hesitancy very complex. I would like to add after tonight also the C of communication. I think that's very clear that lack of communication, miscommunication will also help vaccine hesitancy, and a way to address vaccine hesitancy is the good communication. From Nico Van Dalen, we heard related to the topic of convenience, well, the human component, the logistical component, the system, connection, networks. It all has to do with a lot of complex issues related to the convenience. Tinne de Koene was very clear on her tiny product with a big impact. I like that sentence because sometimes we forget what kind of journey a vaccine has to make from development, the factory, the transportation, up to the point that it needs to be administered at the right anatomic site. Lieke van der A stressed, I think, very importantly, the quality control, and we recommend really to work on a very accessible document, a very easy document, a kind of fact sheet or frequently asked question document to reassure the population, the doctors, everyone, how much attention is given to quality assessment, quality control of the vaccine in general, and drugs, of course, as well. From Heidi Larsen, I think we understood that many factors impact the trust that people have in vaccines, but overall we are now living in an atmosphere of distrust and suspicion, so that doesn't help really to increase confidence in vaccines. The role of limited supply of vaccines, as we heard now for COVID-19, but also for flu vaccines, is also an extra challenge and might also play a role in the hesitant attitude. And she concluded, in fact, by saying teaching tools are very important, and then we moved on. I think that was a superb transition to Sif Nielsen, where we understood that reaching children is important, but also reaching families through children is a very easy way to try to educate more than only the children. Future generation need to be better informed, more informed, also more empowered. And promoting a healthy lifestyle is not something new. It existed already. And as we heard here from the panel, vaccine is part of that package. So we have really to bring over a very good, healthy package on healthy food, movement, being active, and also part of it is sexual health, immunization, hygienic measures, and so on. So I think that's also a message that we will take home. Gamification is something quite new for all of us, I think, but of course there is already a world of gamification who very well understand how to target children. So we can learn from that and create, as we heard, an environment of which the player, of which the children are part of. And that's another feeling. It gives a certain ownership to the game, but ownership also to the messages that are offered through the game. So I think that's what we learned or could learn tonight. I'm very happy to be here with all of you. I wish you a very good way home, a safe way home for those who are here, and those who are at home, I would say take a good glass of wine and have a very nice evening. Bye-bye.